So, very pleasant good afternoon to one all. I'm Dr. Uma Maheshwari. I'm going to start with gastrointestinal drugs. So, the first is drugs for peptic ulcer, which includes antacids, systemic antacid, and a non-systemic antacid. Systemic antacid includes sodium bicarbonate. Non-systemic antacid is aluminum hydroxide, magnesium trisilicate, mecalorate, magnesium hydroxide. Why this is? The most commonly asked question is, which is the systemic antacid among the following? So the systemic antacid is sodium bicarbonate. And the drugs which decreases the acid secretion are proton pump inhibitors, H2 blockers, and anticholinergics. The proton pump inhibitors include omeprazole, pantoprazole, esomeprazole, lansoprazole, and rabeprazole. H2 blockers are cimetidine, ranitidine, famotidine, roxatidine, nizatidine, and loxatidine. The anticholinergics are propancolin, oxyphenonium, tilanzapine. So the drugs increasing the protective factor. So most commonly asked question is, which is the prostaglandin E1 analog among the following? So prostaglandin E1 analog is misoprostol, and prostaglandin E2 analogs are enprostil and rioprostil. Ulceroprotectors include sucralfate, colloidal bismuth substrate, rabapimide, and ecabet. And rabapimide and ecabet acts mainly by increasing the prostaglandin production. And the anti-H. pylori drugs include triple regimen, which is lansoprazole, amoxicillin, and clarithromycin. It is usually said CAP, clarithromycin, amoxicillin, plus a proton pump inhibitor. Due to clarithromycin resistance, now instead of clarithromycin, metronidazole is used. And the quadruple regimen is for 2 weeks. Nowadays, quadruple regimen is followed because of clarithromycin resistance. It includes lansoprazole, metronidazole, tetracycline, and bismuth substrate. Instead of metronidazole and tetracycline, amoxicillin and clarithromycin may be used. The importance of this is, most commonly asked question is, among the drugs, which are the drugs used for H. pylori? So next classification is ulcer healing drugs, which is carbinaloxone. So among this, misoprostol is the prostaglandin E1 analog, which is the most specific drug for the treatment and prevention of NSA-induced peptic ulcer. But the drug of choice for this condition is proton pump inhibitors. So coming to the H2 blockers, it suppresses the nocturnal acid secretion more compared to that of secretory response to food stimulation. They do not have any effect on gastric emptying except by nisatidine. It is used mainly in peptic ulcer disease, gastroesophageal reflux disease, Zollinger-Ellison syndrome, prophylaxis of aspiration pneumonia. In urticaria, it is used along with H1 blockers. The side effect is mainly gastrointestinal distress, dizziness, somnolence, and slurred speech, delirium. This slurred speech and delirium is more common in the elderly. Cimetidine is the major inhibitor of cytochrome P450 enzyme. So a lot of drug interaction is there with cimetidine. Cimetidine is the least potent drug of this class. Cimetidine is an anti-androgen. It decreases the androgen levels and increases the prolactin levels. So they are more prone to cause gynecomastia, galactorrhea, and decreases the libido. The important thing is lafutidine is a drug which increases the nitric oxide production. All H2 blockers are competitive. Loxatidine is a non-competitive antagonist. Famotidine has some inverse agonist activity. Among this class, famotidine is the most potent drug. Lisatidine, they have 100% bioavailability. This is the only drug in this group which enhances the gastric emptying. So now coming to the proton pump inhibitors, they are irreversible direct inhibitors of proton pump in the gastric parietal cell. Proton pump is K plus H plus ATPase. It is the drug of choice for peptic ulcer disease, GERD, Zollinger-Ellison syndrome, and also used in H. pylori regimen. The side effect profile is they produce mild CNS and GA effects. Osteoporosis and decreased B12 absorption, Clostridium difficile infection occurs when it is used for a longer time. The most commonly asked question is the anti-ulcer medication which causes hip fracture is with proton pump inhibitors because on the long-term usage they causes osteoporosis. It is a hit and run drug, and the lansoprazole is the most potent. Rabiprazole is rapidly acting drug, and pantoprazole and rabiprazole has least drug interaction. Pantoprazole, esomeprazole, and lansoprazole are given through the parenteral route. The omeprazole inhibits CYP2C19 and CYP3A4. This interaction is very much important because clopidogrel requires CYP2C19 for their activation. When you give along with omeprazole, omeprazole will inhibit the clopidogrel. Clopidogrel is an antiplatelet drug. So clopidogrel activation will not occur, so the antiplatelet effect will not be seen. So the important interaction between omeprazole and clopidogrel is mediated by CYP2C19. The proton pump inhibitor, I said it is an irreversible inhibitor of potassium pump, but reversible potassium competitive acid blocker is vonoprazole and revaprazole. And cytoprotectors include misoprostol. It is prostaglandin E1 analog. It increases the mucus and bicarbonate secretion but decreases the HCl secretion. It is the specific drug for NSAID-induced gastrointestinal ulcer. Rabapivir and etabat occurs by mechanism of action is by it increases prostaglandin production. Ulcer protector is sucralfate and bismuth subsalicylate. Sucralfate, they require acidic pH. The most important interaction is with antacids because antacids will raise the pH. It will not cause the sucralfate activation. So at the acidic pH, it polymerizes on the gastrointestinal luminal surface and it forms a protective gel. Main adverse effect with this drug is hypophosphatemia and constipation. Bismuth subsalicylate, it is used in combined with metronidazole and tetracycline to eradicate H. pylori. Main adverse effect is blackening of the tongue, bismuth toxicity, which is more prone in case of renal failure. They produce osteodystrophy and encephalopathy. So antacids, they are the base which neutralize the gastric acid. Among this, the systemic antacid is sodium bicarbonate. Others, aluminum hydroxide, calcium carbonate, and magnesium hydroxide. And in this, the systemic antacid, it causes the retention of sodium. So it produces the gas, which is manifested as belching. So and also causes retention of sodium, leading to congestive heart failure and hypertension. And among this, calcium carbonate and sodium bicarbonate, they are short acting, so they are more prone to cause alkalosis, and acid rebound is common with this drug. Aluminum, they causes constipation. Magnesium, they causes diarrhea. Aluminum, the main adverse effect is osteodystrophy and dementia. Calcium carbonate, when it is given along with milk, they causes milk alkali syndrome, produces hypercalcemia and renal insufficiency. In magnesium hydroxide, it is more common with in renal failure. They causes hypermagnesemia, loss of the tendon reflexes, and respiratory paralysis. And now coming to the antiemetic drugs, the drug for motion sickness is scopolamine, which is hyoscine. And the antiemetic drug in pregnancy is doxylamine with pyridoxine. Doxylamine is an antihistamine which is given along with pyridoxine. For chemotherapy and radiotherapy induced vomiting, the drug of choice is 5-HT3 blockers like ondansetron. So chemotherapy, mainly cisplatin-like drugs, they produces emesis. They occurs in the acute phase and also in the delayed phase. In the acute phase and on the day or 1 or 2 days, they will produce the emesis. The delayed emesis, it occurs after 1 week. So in the delayed phase of chemotherapy-induced nausea, vomiting, the drug of choice is selective NK1 receptor antagonist, that is substance P antagonist, aprepitant. And also fosaprepitant is the derivative of aprepitant. And for vertigo, it is cinnarizine. And dronabinol, it is a cannabinoid which acts by mainly on cannabinoid 1 receptor. It is used for AIDS-related cachexia. And other antiemetics are dopamine antagonist, H1 antagonist, benzodiazepines, and steroids. They are adjunctive antiemetics. So now coming to the 5-HT3 antagonist, ondansetron, they have shortest T-half. The palonosetron, they have longest T-half. They are the most potent. They have highest affinity. I already said they are used mainly for acute phase of vomiting, and for the delayed phase of vomiting, drug of choice is aprepitant. But among the 5-HT3 antagonists, the palonosetron is the only drug which is approved for delayed chemotherapy-induced nausea, vomiting. And ramosetron, it is used for diarrhea predominant irritable bowel syndrome, because ramosetron, they normalize the colonic function. And now coming to the prokinetic drugs, the important thing is metoclopramide. Its action is antagonized by atropine. Because normally the acetylcholine is the major neurotransmitter in the GIT, because it's the prokinetic action by D2 blocking, 5-HT3 antagonist, and 5-HT4 agonistic activity. Because of the D2 blocking action, they produces extrapyramidal side effects and hyperprolactinemia. And the next drug is domperidone. They do not crosses the blood-brain barrier. The mechanism of action is only D2 blocking. So as they do not cross the blood-brain barrier, there is no extrapyramidal side effects with this drug, but hyperprolactinemia is very rare. And cisapride, nosapride, and checosirone, they are 5-HT4 agonists. They do not have any action on D2 receptors. Cisapride, they are more prone for QT prolongation, and it is more with CYP3A4 inhibitors. Nosapride will not have any QT prolongation. Checosirone has been withdrawn from the market because of it myocardial infarction and stroke. Etopride, it is a drug which crosses D2 blocking. There is no EPS, there are no arrhythmias, and no hyperlactinemia is also very rare with this drug. They do not produce any drug interactions also, because they are metabolized by flavin mononuclease, FMN. And loxyglutamine is a drug which causes CCK receptor antagonist. And now coming to the laxatives, this is the classification. The most commonly asked thing is, which is the stimulant purgatives among the following, which is the 5-HT4 agonist, which is the prostaglandin analog, which is used as which is a laxative. So the prostaglandin analog used as a laxative is lubiprostone, and 5-HT4 agonist is prucalopride, and other stimulant purgators are bisacodyl, sodium picosulfate, senna, cascara sagrada. And the bulk forming agents are bran, psyllium, esophagula, methylcellulose. The stool softeners are docusades and liquid paraffin. So osmotic purgators, they are magnesium sulfate, hydroxide, sodium sulfate, phosphate, sodium potassium tartarate, lactulose and lactulose. Among the osmotic purgators, lactulose is very much important. These bulk forming agents should not be used in intestinal obstruction. Magnesium sulfate is contraindicated in renal failure because they causes the accumulation of magnesium. Sodium salt is contraindicated in the congestive heart failure. Senna, cassia, they are prone to cause melanosis coli. And lactulose is used in the treatment of encephalopathy. Lubiprostone is the prostaglandin analog, commonly asked question, which is the prostaglandin analog, which is used as a laxative, lubiprostone. And 5-HT4 agonist is prucalopride. And which is the drug used for opioid-induced constipation is methylnaltrexone and alvimepin. They are peripheral opioid antagonists. The opioid-induced constipation, the drug used is methylnaltrexone, alvimepin. And antidiarrheals, the opioid includes loperamide and diphenoxylate. It is given along with atropine to prevent the abuse liability. But it should not be given in infective diarrhea because it will cause toxic megacolon. The somatostatin analog used as an antidiarrhea is octreotide. It is used mainly for secretory diarrhea. And encapsulase inhibitor, rasicadotril. It is also used for secretory diarrhea. The recent MRB also they have asked which is the encapsulase inhibitor among the following. It is rasicadotril. And CFTR channel inhibitor is crofelemer. It is used for diarrhea in AIDS patient. And adsorbents includes thiolin and pectin. This is not used much nowadays, adsorbents like drugs. And the drugs for inflammatory bowel disease, it is mainly aminosalicylates, 5-aminosalicylate and sulfapyridine. The sulfapyridine component is used in rheumatoid arthritis and 5-aminosalicylate component is used in ulcerative colitis. And it is not effective for Crohn's disease. Glucocorticoids, they are used mainly in moderate to severe, both ulcerative and colitis and Crohn's disease. And it is used mainly in exacerbations. In the purine analogs like azothioprine, 6-mercaptopurine, it is used mainly in the maintenance of remission in ulcerative colitis and Crohn's disease. Methotrexate for maintenance of remission in only Crohn's disease, but not in ulcerative colitis. The other anti-TNF alpha therapy includes infliximab, adalimumab, cetrolizumab. In this infliximab, it is used as IV. Adalimumab and cetrolizumab is given by subcutaneous route. It is used for both in chronic disease and ulcerative colitis. And natalizumab, it is an anti-integrin therapy. It is against alpha-4 subunit of integrin. The most common adverse effect of this drug is it will cause progressive multifocal encephalopathy. And with vedolizumab, it is also anti-integrin therapy for against alpha-4 and beta-S subunit, but there is no progressive multifocal leukoencephalopathy with this drug. There are many drugs which causes progressive multifocal leukoencephalopathy. It is natalizumab, prednisolone, fludarabine, and brentuximab, rituximab. And the drugs for irritable bowel syndrome, it includes drugs for diarrhea, constipation, and the treatment of abdominal pain. For the diarrhea, it is antidiarrheals like loperamide, cholestyramine, alocetrone, peptozin. Allocitron here is 5-HT3 antagonist. Fedotoxin is a kappa 1 agonist. For constipation, laxatives are used. Lubiprostone, linaclotide, and proloqupride are used. For abdominal pain, smooth muscle relaxants, tricyclic antidepressants, and selective serotonin reuptake inhibitors are used.
Oh,
Shall
Audio.
Okay. So now start with the respiratory system. So it includes drugs for productive cough and non-productive cough. Productive cough should not be suppressed. So for that, expectorants are used. For non-productive cough, you have to use cough suppressants. So for productive cough, it is expectorant. It is of two types: secretion enhancers and mucolytics. The secretion enhancer is mainly potassium iodide. It acts by direct mechanism and indirect mechanism. Directly by irritating the bronchial glands and indirectly by gastric irritation. So main adverse effect with this secretion enhancer is it causes hypothyroidism, flaring up of acne when it is used in adolescent females, and it also prone to cause cretinism when it is given for pregnant women. In mucolytics, it is bromhexin ampreoxyl. Ampreoxyl, it is a metabolite of bromhexin. Acetylcysteine and carbocysteine, they act mainly by breaking the disulfide bonds in the sputum, so that makes the sputum less viscid, so that it can be easily expectorated out. So acetylcysteine and carbocysteine, they are more prone to cause gastritis. So these are antitussives, cough suppressants, that is, they raises the cough threshold and prevents the cough. Opioids and non-opioids, it is codeine and folcodeine, and it causes constipating and narcotic effects. And with non-opioids, it is noscapine and dextromethorphan. There is no constipating or narcotic effects with this non-opioids. And the peripheral antitussive is prinoxidazole. They act mainly by desensitizing the stretch receptors in the respiratory system. So the most important thing is the peripheral antitussive is prinoxidazole. And now coming to the drugs for bronchial asthma, this three is mainly comes under bronchodilators: beta-2 sympathomimetics, methylxanthine, and anticholinergics. In beta-2 sympathomimetics, the drug is salbutamol, terbutaline, bombuterol, salmeterol, and formoterol. And methylxanthine, theophylline, aminophylline, choline theophyllinate, doxophylline. The anticholinergics are ipratropium bromide and tiotropium bromide. Why this classification is, the commonly asked thing is, which is the bronchodilators among the following? They will give the beta symptomatic, methylxanthine, and anticholinergic along with the corticosteroid. So corticosteroid is the drug among this which will not cause any bronchodilation. And leukotriene antagonist, it is montelukast, zafirleukost. Mast cell stabilizer, sodium chromoglycate, and ketotifen. The corticosteroids, which is systemic and inhalational. Systemic is hydrocortisone and prednisolone. Inhalational is beclomethasone, budesonide, fluticasone, flunisolide, and cyclisonide. This cyclisonide is the soft steroid because they get metabolized by the esterase present in the lungs. So they are said to be soft steroid, cyclisonide. And the anti-IgE antibody is omalizumab. Most commonly asked question is, which is the IgE antibody which is used for bronchial asthma? It is omalizumab. And now treatment for the acute attack of bronchial asthma. For the acute attack, we will be giving bronchodilators. In this sympathomimetics, it is the fastest acting drug by inhalational route. There are of two types, non-selective and selective. Non-selective is adrenaline, isoprenaline, and ephedrine. What happens? It will stimulate both the beta-1 and beta-2 receptors. Beta-1 receptor is present in the heart, so it will cause tachycardia. So it should be caution in hypertensives and ischemic heart disease. The short-acting drugs like salbutamol, terbutaline, they are given for the acute attack. Long-acting, there is salmeterol, there is meter in this, so it is long-acting, salmeterol, bombuterol, and formoterol. They are used mainly for prophylaxis of asthma, that is exercise-induced asthma, and to decrease the nighttime attacks. The most common adverse effect of this group is it will cause muscle tremors, and cardiovascular toxicity. The electrolyte abnormality is hypokalemia. The most common adverse effect is muscle tremors. Mechanism is they act mainly by increasing the cyclic AMP, so they produces bronchodilation. Salbutamol, they have fast onset of action, but solmetrol, they have slow onset of action. For this reason only, salbutamol is used in the status asthmaticus, but not solmetrol. Bambuterol, they are prodrug of terbutaline. The very long-acting beta agonists, they are voladaterol, bulanterol, and indacterol. Their action is for more than 24 hours. And coming to the next group, anticholinergics or parasympatholytics. Their main action is on the larger airways. So they are more effective in the COPD than the bronchial asthma. There are two drugs, ipratropium bromide and tiotropium bromide. Among this, ipratropium bromide is short-acting, tiotropium bromide is long-acting, and they are more effective. They are M3 antagonist, so that the anticholinergic side effects are very less with this group of drugs. This drug is given only through the inhalational route. This is the bronchodilator of choice in patients who are undergoing beta blocker therapy. And methylxanthines, mechanism of action is it inhibits phosphodiesterase, thereby increasing cyclic AMP, and they causes antagonism of adenosine. These two mechanisms of action occurs at the therapeutic range, that is 5 to 15 microgram per ml. But above the therapeutic range, they causes the release of calcium from the sarcoplasmic reticulum. They have a narrow therapeutic window. They follow the saturation kinetics. Therapeutic drug monitoring has to be done while giving methylxanthine. Among the clearance, the children clear its theophylline faster, and it is slower in elderly and premature infants. And now coming to their actions, that is what happens when you have a coffee. There will be CNS stimulation, heart there will be stimulation, blood vessels there will be relaxation, bronchus dilatation, they produces diuretic effect in the kidney, and the skeletal muscles, they increases the contractility. Very much important thing is the skeletal muscle contractility produced by caffeine is more compared to that of theophylline. This is the one commonly asked question. Caffeine, they produces more increased contractility than theophylline. So in the gastric mucosa, they causes irritation, and they produce phosphodiesterase inhibition and adenosine antagonism. So the toxicity, it's an extension of pharmacological effects. So in the 5 to 15 microgram per ml, it is in therapeutic range. Only a headache, this insomnia, dyspepsia, nervousness will be produced. At above the 20 microgram per ml, there occurs tremors, vomiting, agitation, tachypnea, flushing, hypotension. Mainly they produces cardiovascular side effects and CNS side effects. That is arrhythmias, convulsions, shock, and death occurs with this drug. And aminophylline parenterally is given for status asthmaticus and COPD. It is also used in apnea of premature infants because they causes the contraction of the diaphragm. And the dose reduction has to be needed in age more than 60 years, in congestive heart failure, pneumonia, and dose reduction has to be done. And along with the drugs like erythromycin, ciprofloxacin, cimetidine, and oral contraceptive pills, the dose has to be reduced. Mast cell stabilizer, it includes nitochromyl and sodium glycate, ketotifen. So among this ketotifen, they have an antihistaminic property. They produce sedation. The most commonly asked question is, which is the mast cell stabilizer which produces sedation? It is ketotifen. Antihistaminic, so sedation. Cromolyn and nidochromyl, they act mainly by inhibiting the bronchial hyperreactivity. So they are used in the bronchial asthma because they are stabilizing the mast cells. They are used in allergic rhinitis and allergic conjunctivitis. And glucocorticoids, important thing is it is not a bronchodilator. It is an anti-inflammatory agent. They causes decrease in the bronchial hyperreactivity. So the systemic steroids, they will cause more adverse effects. So the systemic steroids has to be given only for severe chronic asthma and status asthmaticus. The inhaled steroids, they have less systemic effects. The side effects, it includes oropharyngeal candidiasis. For that, antifungal like anistatin can be given, and they causes hoarseness of voice. They prevents the desensitization of beta receptors that can occur when you use beta-2 agonists for a long time. And anti-leukotrienes, it is zafirleucost and monteleucost. They causes the antagonism of leukotriene D4 receptor. The question will be, which is the leukotriene D4 receptor antagonist? They will give you zafirleucost and also xylutone as an option. So we'll be having a confusion whether it is xylutone or zafirleucost. So you remember zafirleucost, they have R in it, and also it antagonize the receptors. Zafirleucost, they antagonize the receptors. Xylutone, it is an inhibitor of lipoxygenase, so it decreases the formation of all leukotrienes. And also the difference is zafirleucost and monteleucost, it is slow onset of action. Xylutone, it has a rapid onset of action. Exercise-induced asthma, aspirin drug-induced asthma. Xylutone, it is used adjunct to steroids. And based on the side effect profile, this is also commonly asked question, which drug causes Church-Strauss syndrome is as a side effects. Even though it is a rare side effect, which is vasculitis with eosinophilia, it is commonly asked thing. So it is with zafirleucost. And xylutone, they will cause hepatotoxicity. It is an anti-Ig monoclonal antibody that inhibits the binding of Ig to mast cells. They are given by the subcutaneous routes. It is used only in people where the Ig levels are high. The disadvantage with this drug is it is most costly. And phosphodiesterase 4 inhibitors are roflumilast and silomilast. And the monoclonal antibodies which is directed against interleukin 5 is mepolizumab and reslizumab. These are the newer drugs used for bronchial asthma. And the anti-asthmatic drugs which is given as an inhalation route. So inhalation route, these drugs are given. You remember is A, B, C. A, anticholinergics, B, beta-2 agonists, C, corticosteroids, and sodium chromoglycate. These drugs can be given in inhalational route. And status asthmaticus, it is a life-threatening condition in which parenteral steroid hydrocortisone is used, nebulized salbutamol along with ipratropium bromide, high-flow oxygen, salbutamol, and terbutaline. And aminophylline, when there is no response with this medications, you can go for aminophylline. And asthma, it is a resistant asthma. It will not respond to beta-2 agonist. There are two types. In type 1, the drug of choice is terbutaline, and type 2, the drug of choice is. So next is the autocoids. So they release substances which will act locally. That is the autocoids mean. So it includes histamine or G protein couple second messenger effectors. There are 4 receptors, H1, H2, H3, and H4. Among this, H3 is presynaptic. Presynaptic is on stimulation of this receptor, it inhibits its own release. H4 is chemotaxis. So among this histamine, H3 is presynaptic. Among serotonin, 5-HT1 receptor is presynaptic. So they will ask you which is the autoreceptor or presynaptic receptor among the following. So in the histamine, H is H3 and in serotonin, it is 5-HT1 receptor is autoreceptor. Due to H1 receptor activation, there will be increased capillary dilatation, which causes fall in BP, and increased capillary permeability, and increased bronchial smooth muscle contraction, and they causes the activation of the nociceptive receptors, which causes the pain and pruritus. And due to H2 activation, they causes the increase in gastric acid, so they produces gastric ulcers. So that only H2 blockers are used for peptic ulcer. And among this histamine analog, which is beta histone, it is used for vertigo. And these are the drugs which releases histamine. There is PV-MAT, polymyxin, vancomycin, morphine, atropine, and tuberculin. These are the drugs which releases histamine. And now we have a comparison between first generation and second generation histamine. Among this, promethazine, chlorpheniramine, meclizine, hydroxyzine. They are first generation antihistamine. Loratadine, fexofenadine, or second generation antihistamine. So the first generation, they produces M block. They have anticholinergic effect, and they produces they blocks the histamine receptors. They produces sedation. Because of the anticholinergic action, they produces anti-motion effect also. But this is not seen with the second generation antihistamine. The anticholinergic blockade is not, the anticholinergic effect is not seen with second generation antihistamine. So they're not used in the motion sickness. Among the first generation group, promethazine, they have additional alpha block and local anesthetic action. Chlorpheniramine, in some individuals, they produce a CNS stimulation. Usually they are sedatives, but chlorpheniramine, in some people, they produce a CNS stimulation. Meclizine, they are highly effective in motion sickness, mainly in seasickness. In hydroxyzine, it is commonly used as a sedative. But loratadine, fexofenadine, they are second generation antihistamines. There is no entry in the CNS, so they will not produce sedation or they will not have any anti-motion effects. So what's the advantages of using second generation antihistamine is they will not produce any sedation, no CNS depression. They are highly H1 selectivity, no anticholinergic side effects, but they have additional anti-allergen mechanism. The drugs of fexofenadine, loratadine, cetirizine, azilastin, misolastin, avastin, and rupatadine. Also desloratadine, levocetirizine, they also comes as second generation antihistamines. So the uses is mainly used in allergic reaction, and for this condition like motion sickness, nausea, vomiting, for preoperative sedation, sedative, and for drug-induced Parkinson's and extrapyramidal symptoms. That is first generation antihistamines. That is, a drug with an anticholinergic activity has to be used. So for these conditions, it is the first generation antihistamines which is useful. An adverse effect, it is mainly the extension of M block, that is anticholinergic side effects. And they produces sedation, gastrointestinal distress. And serotonergic system, serotonin synthesized from tryptophan. It is metabolized by monoamine oxidase. Its metabolite is 5-hydroxy-indole acetic acid, which is a marker for carcinoid syndrome. So among this, all are G protein coupled receptors. The receptors are 5-HT1, 2, 3, 4 to 7. All are G protein coupled receptors except 5-HT3, which is a ligand gated ion channel. Among these receptors, 5-HT1 is an autoreceptor. So important drugs acting on the receptor is buspirone, which is an anti-anxiety agent. It has a partial agonist at the 5-HT1A receptor. Sumatriptan, they have agonist action over the 5-HT1B and 1D receptor. They are used for the migraine. Olanzapine and other atypical antipsychotics, they have antagonist action over the 5-HT2A receptors. Cyproheptadine, they are 5-HT2 antagonist used in carcinoid, and it is also an appetite stimulant. It also have antihistaminic and anticholinergic effect. 5-HT3 antagonist or ondansetron, they have seen now only. 5-HT4 agonist, it is tegosterone. Irritable bowel syndrome with constipation, it is used. And 5 to 7, they are future research receptors. And now coming to the drugs for migraine, based on the severity, that is mild attack, less than 1 attack per month, lasting for 8 hours, it is with simple analgesic like NSAIDs, and moderate, that is 1 or more than 24 hours, and also it incapacitates the individual. You can go for NSAIDs or triptans or ergot alkaloids. For the acute attack of migraine, the drug of choice is triptans. That is severe, that is 3 or more attacks, more than 48 hours, and also vertigo, vomiting, and it also grossly incapacitated the patient. Triptans or ergot alkaloids, and prophylaxis is indicated in severe migraine. In some books, it is given it is moderate to severe migraine. Prophylaxis is indicated. In few, they have given prophylaxis for severe attacks. So it is for more than 2 to 3 attacks per month, we can go for prophylaxis. So what is the difference between ergots and triptans? Triptans, they are drug of choice for acute attack. They act mainly on 5-HT-BD receptor. And ergotamine, dihydroergotamine, ergotamine, it is given in oral and sublingual route. Dihydroergotamine, it is given through the parenteral route. It is usually combined with caffeine because caffeine enhances the effect of ergot. But major disadvantage with ergot is it increases the nausea and vomiting which occurs in migraine. But this is the advantage with triptans, it also suppresses the vomiting. But the disadvantage with triptan is because it causes vasospasm in the coronary vessels also. So it is contraindicated as the ischemic heart disease and hypertension. And sumatriptan is the drug which is shortest acting. Provatriptan, it is longest acting but slowest onset of action. Rizatriptan, they have fastest onset of action. And for prophylaxis, these are the drugs used. Among the beta blockers, propranolol is the most commonly used drug. Others include metoprolol, atenolol, timolol, tricyclic antidepressants or amitriptyline, calcium channel blockers like verapamil and flumarizine. Anticonvulsants, it includes valproic acid, gabapentin, and topiramate. This is a new drug, erinumab, calcitonin G-related peptide antagonist, erinumab. It is given through subcutaneous route once a month. And serotonin antagonist, methotrexate and cyproheptadine, it is not preferred nowadays because other efficacious drugs are available. So the serotonin antagonist is not preferred nowadays. And ergotamine, it is agonist and antagonist at alpha and 5-HT2 receptors in the vasculature and in the CNS. Main mechanism is they causes vasoconstriction. So it decreases the pulsation in the cerebral vessels. So they are used in migraine attack. Because of the prolonged vasoconstriction, they may produce ischemia and gangrene, and they causes abortion near term. Now coming to the leukotrienes, they are formed from the lipoxygenase on arachidonic acid. Among this, leukotriene A4 is produced first, followed by B4, C4 and D4. Among this B4, it is chemoattractant. They activate polymorphonuclear cells leading to radical formation and cell damage. The C4, D4 and A4, they are involved in anaphylaxis and bronchoconstriction. So C4 and D4, they are called as slow reacting substance of anaphylaxis. So in this slide, the important thing is leukotriene B4 is chemoattractant. C4 and D4, they are said to be slow reacting substance of anaphylaxis. And prostaglandins, they are formed from the action of cyclooxygenase. Three types are there: cyclooxygenase 1, 2, 3. Constitutive one, it is present in our body. It is mainly concerned with gastroprotection. And COX2, it is inducible. It will be induced only in the presence of inflammation. And COX3 is involved in pain perception and fever. Then NSAID, which acts on the COX3 is paracetamol. Paracetamol, they acts by inhibiting the cyclooxygenase 3. So these are prostaglandin analogs. Prostaglandin E1, misoprostol. Already we have discussed. It is used in NSAID-induced ulcer. Along with mifepristone, it is used for abortion up to 7 weeks. And alprostadin, it maintains the patency of ductus arteriosus. It produces vasodilatation, so it is used in male impotence. Prostaglandin E2, it is dinoprostone. E2, dinoprostone, is used in cervical ripening and it is also used as an abortifacient. Prostaglandin F2 alpha, it is carboprost and dinoprost. Dinoprost is used for abortifacient, postpartum hemorrhage, and for the induction of labor. And latanoprost, bimetoprost, they are used for the treatment of glaucoma. And prostacyclins, the drug is epoprostinol, which is used for pulmonary hypertension and peripheral vascular disease. Coming to the non-steroidal anti-inflammatory drugs, they act mainly by inhibiting cyclooxygenase 1 and cyclooxygenase 2. Aspirin is a drug which causes irreversible inhibition of cyclooxygenase. So this is the classification of NSAIDs. Most commonly classified as selective COX2 inhibitors. They are also known as Koncpts. So the drugs are celecoxib, etoricoxib, and parecoxib. And the NSAID, which NSAID has poor anti-inflammatory action is, it is paracetamol. And nifopam also has poor anti-inflammatory action. The nifopam is a drug which produces its mechanism by which produces action without inhibiting the prostaglandins. All NSAIDs, they act by inhibiting the prostaglandin production. Nifopam is a drug which does not inhibit the prostaglandin production. It is also called as atypical drug. And the non-selective groups includes salicylate aspirin, propionic acid is ibuprofen, naproxen, ketoprofen, and flurbiprofen. Propionic, that aids with propofen. Phenamate, it is mefenamic acid. Enolic acid derivatives are piroxicum and tanoxicum. The importance with this group is they are the longest acting NSAIDs because they undergoes enterohepatic circulation. The acetic acid derivatives are ketorolac, indomethacin, nabumetone. And pyrrole is known as phenylbutazone. They causes agranulocytosis. And preferential COX2 inhibitors, that is, they inhibit COX2 more compared to that of COX1. The important drugs of the group is aceclofenac, diclofenac, nimesulide, meloxicam, and etodolac. So what's the importance of cyclooxygenase 1 and 2 inhibition? Because of cyclooxygenase 1 inhibition and 2 inhibition, we have analgesic, antipyretic, and anti-inflammatory effect. But these COX2 inhibitors, they do not have antiplatelet effect. And they also will not cause gastric mucosal damage. But they cause renal salt water retention, they prolong the labor. So this is what, when we use COX2 inhibitors alone, that is Koncpts, they do not have any anti-aggregatory effect and they do not produce any gastric mucosal damage. That is, they are more prone for thrombosis, but they have gastroprotection. So paracetamol is the drug which acts by inhibiting cyclooxygenase 3. They do not have any anti-inflammatory effects. N-acetyl parabenzoquinone is a metabolite produced by paracetamol, which has a propensity to cause hepatotoxicity. N-acetylcysteine is the antidote for paracetamol poisoning. Aspirin, they are irreversible inhibitor of cyclooxygenase. At the low dose, they have antiplatelet effects. And metabolic effects is with respiratory alkalosis and metabolic acidosis. They prolongs the bleeding time and it causes hyperuricemia. But at a dose more than 5 grams per day, they increases the uric acid secretion. But it is not used for an gout because it is not a dependable uricosuric. It is not used in children less than 12 years due to Ray's syndrome. When it is used for varicella-like infection, they are more prone to cause Ray's syndrome, that is hepatic encephalopathy. And indomethacin, they causes headache. So the analgesic which causes pain is indomethacin. So the analgesic causing pain is indomethacin. Paroxetine and tanoxetine is the longest acting NSAID because they undergoes enterohepatic circulation. Phenylbutazone, they causes agranulocytosis. Selective COX-2 inhibitors, I already said, they are more thrombosis but less GI toxicity. The drugs etoricoxib, they are longest acting. Parecoxib, they are given parenterally. And celecoxib, they will cause rash. And the NSAID which do not inhibit prostaglandin is mifopam. Now coming for the drugs for rheumatoid arthritis, it is hydroxychloroquine, which stabilizes the lysosomes and they decreases the chemotoxis. And it is side effect is they causes GI distress, visual dysfunction, which is less with hydroxychloroquine compared to that of chloroquine. And it causes hemolysis and glucose 6-phosphate dehydrogenase deficiency. And methotrexate, it is a dihydrofolate reductase inhibitor. They are cytotoxic to lymphocytes. Their side effect is mainly hematotoxicity and mucositis. Sulfasalazine, we have seen this drug in another place also. That is in ulcerative colitis. 5-aminosalicylic acid and sulfaparidine. This sulfaparidine, they decreases the B cell functions. 5-aminosalicylic acid, they inhibits the cyclooxygenase. So the main adverse effect with this, they produces hemolysis in G6PD deficiency and also SLE-like syndrome. Glucocorticoids, they are anti-inflammatory. They decreases the leukotrienes, interleukins, and platelet activating factor. The adverse effect is they produces ACTH suppression, Cushingoid state, osteoporosis, and GI distress. They are prone for glaucoma and cataract. Gold salts and penicillamine, they are not used nowadays because of hematotoxicity and nephrotoxicity. And coming to the most important part, TNF alpha blocking drugs. They are etanercept, infliximab, adalimumab. They act mainly by inhibiting TNF alpha. The main adverse effect is they causes infusion site reaction and hypersensitive reaction. They also causes the flaring up of tuberculosis. Before giving the drug, you have to check whether the patient have any pulmonary tuberculosis because they will reactivate the tuberculosis. And leflunomide, they act by inhibiting dihydroorotic acid dehydrogenase. This is the commonly asked question. The drug which acts by inhibiting dihydroorotic acid dehydrogenase is leflunomide. So as such, they causes arrest lymphocytes in G1. So the side effect is alopecia, rash, diarrhea, and hepatotoxicity. Anakinra is a drug which causes interleukin-1 receptor antagonist action. So the main adverse effect is infection and injection site reaction. And co-stimulation inhibitors, they inhibit CD80 and 86. They are needed for the activation of CD28, which is present in the antigen present cells. So they causes T cell activation. These drugs abatacept and belatacept, They inhibits the activation of the CD80 and 86. And rituximab, they depletes the B cell. Tocilizumab and tocilizumab, they are newer drugs. Tocilizumab, IL, tocilizumab. So they are active against interleukins. Tocilizumab, they are mainly active against JAK3 and JAK1 kinase inhibitor. These are the drugs used for rheumatoid arthritis. And the drugs for gout, it includes for acute gout and chronic gout. For acute gout, it is NSAIDs, colchicine, corticosteroids, which is given through the intra-articular route. And the uricosuric includes probenecid, sulfenpyrazone, lesinurab. And the synthesis inhibitors of allopurinol and febuxostat. And the drugs which causes hyperuricemia, that is secondary hyperuricemia, thiazides and furosemide, they are diuretics. Pyrazinamide and ethambutol, anti-TB drugs, and levodopa. These are the drugs which causes hyperuricemia. And the drug colchicine, it is mainly used in the acute gout. Mechanism is they binds to tubulin, prevents the tubular polymerization. They cause the metaphase arrest. The most important, most limiting side effect of colchicine, it causes diarrhea. And chronic adverse effect is they produces kidney damage and muscular damage, and the death occurs mainly due to respiratory failure. Allopurinol, it is a pro-drug. It acts mainly by inhibiting xanthine oxidase, so that purine formation will not be there. So it is used in cancer chemotherapy and radiation therapy. Main adverse effect with this drug is they produces hypersensitivity reaction. That is rash is the most common adverse side effect with allopurinol. And they acts mainly by inhibiting the tubular reabsorption of urates. They also inhibits the secretion of many drugs like cephalosporins and fluoroquinolones, so that they are used in the subacute bacterial endocarditis. The main adverse effect with this drug is they causes GI distress and crystallization of the urine. So increased amount of water has to be taken while you give probenecid. And the drug increasing the metabolism. Uricase, that is urate oxidase, they metabolize the insoluble uric acid to soluble allantoin. So rasburicase and pegloticase is the drug which increases the metabolism and causes the excretion of uric acid. Among the pegloticase, they are pegylated compounds, so they are long acting. So these are the drugs used for gout. Next is the central nervous system. So the first group is sedative and hypnotics. They act mainly on the GABA benzodiazepine chloride channel. They causes the opening of this channel, causes the conductance of chloride, leading to CNS depression. So the GABA, they increases the duration of the channel opening. The two drugs, barbiturates and benzodiazepines, they act on the GABA benzodiazepine chloride channel. Among this, barbiturates, they bind either in the alpha or beta subunit. They have 5 subunits, 2 alpha, 2 beta, and 1 gamma subunit. Barbiturates, they bind either in alpha or in beta. Benzodiazepines, they bind in the interface between alpha and gamma. So among this, barbiturates, they increase the duration of the chloride channel opening. Benzodiazepines, they increase the frequency of chloride channel opening. The important thing is barbiturates, they increase the duration. Benzodiazepines, they increase the frequency of chloride channel opening. So bicuculin is a drug which is a competitive inhibitor of GABA. Among this, beta carbolin, it is an inverse agonist at benzodiazepine. Commonly asked question, inverse agonist at benzodiazepine site is beta carbolin. Competitive antagonist at benzodiazepine is flumazenil. Flumazenil is the antidote for benzodiazepine poisoning. It is a competitive antagonist. And this is a classification of sedative and hypnotics. Among this, barbiturates, benzodiazepines, newer hypnotics, other drugs were included. Barbiturates, long acting, short acting, ultra short acting. Among this, phenobarbital and thiopentone is commonly used. Phenobarbital in epilepsy and thiopentone in anesthesia we are using. Other drugs it is not used much, but the longer acting one is phenobarbital, short acting is pentobarbital and butobarbital. Ultra short acting is thiopentone and methoxytone. And benzodiazepines, hypnotic, anticonvulsant and anti-anxiety it is used. As an hypnotic, it is diazepam, alprazolam, flurazepam, lorazepam, nitrazepam, flunitrazepam, temazepam, triazolam, and midazolam are used. As an anticonvulsant, only these drugs: diazepam, lorazepam, clonazepam, and clobazam. For anti-anxiety, it is diazepam, lorazepam, alprazolam, oxazepam, chlordiazepoxide, and clonazepam. And the newer hypnotics, they are also called as Z drugs: zopiclone, zolpidem, and zaleplone. And DORAs. DORAs is dual orexin receptor antagonist. It is a newer drug, suvorexant, and melatonin receptor agonist, ramiltion. These are the drugs used as a sedative and hypnotics. So DORAs is dual orexin receptor antagonist. This is suvorexant. And what's the difference between benzodiazepine and barbiturates? Benzodiazepine, they increase the frequency of chloride channel opening. Barbiturates, they increase the duration of chloride channel opening. So metabolism, it occurs in liver in benzodiazepine. Barbiturates, it also occurs in the liver, but it's an inducer of cytochrome P450. So there will be a lot of that interaction with barbiturates compared to that of benzodiazepines. So phenobarbital in seizures and thiopentone in anesthetic. It is used. These are the use of barbiturate. Benzodiazepines, it is used for many conditions. We'll be seeing late. So the adverse drug reaction is benzodiazepines. They produce anterograde amnesia. They produce dose-dependent CNS depression and respiratory depression, which is very less compared to that of barbiturates. But it is therapeutic window is narrow with barbiturates. CNS depression, respiratory depression is more with barbiturates. So tolerance and dependence, both causes tolerance and dependence, but it's more with barbiturates. An antagonist, the specific antagonist for benzodiazepine is flumazenil. There is no specific antidote for barbiturates. Forced alkaline diuresis has to be done. And for contraindication, acute intermittent porphyria is the absolute contraindication for barbiturates usage. And the benzodiazepines which undergoing extrahepatic metabolism, that is outside the liver, OTL, outside the liver, oxazepam, temazepam, and lorazepam. And short-acting benzodiazepine, it is toll, short-acting, that is temazepam, triazolam, oxazepam, lorazepam, and estazolam. Because it is short-acting, it can be used in liver failure and also in elderly. So when the drug is short-acting, it can be used for sleep onset insomnia. When it is long-acting, it can be used for daytime anxiety. And the benzodiazepine which is used in day trip drug is flunitrazepam. So these are the uses of benzodiazepines. For any acute attack of panic attacks, phobias, benzodiazepines are the drug of choice. They are used in anxiety, for pre-op sedation, status epilepticus, pre-op sedation, sedative and hypnotic. These are the uses of benzodiazepines. Among this, alprazolam is the most commonly used anxiolytic. Diazepam is the longest acting drug. Midazolam is the shortest acting benzodiazepine. This midazolam, they causes ataxia and blackouts in elderly. And triazolam, usually these drugs, they will sedate and calm down the patient. But triazolam is a drug which causes aggressiveness. Early morning waking will be there because it is a short acting drug. So the drug which causes aggressiveness is triazolam. And non-benzodiazepine drugs, there are zopiclone, zolpidem, zaleplon. Among these drugs, zaleplon is the shortest acting drug. They act mainly through the benzodiazepine 1 receptors. So they do not produce any tolerance, no abuse liability, no dependence with than compared to that of benzodiazepines. These effects can also be reversed by flumazenil. So they are not effective in anxiety, seizure disorder, or for muscle relaxation. It is used only as a sedative and hypnotic. Now coming to the alcohols, ethanol. First alcohol, it is metabolized by alcohol dehydrogenase. They produce acetaldehyde, and acetaldehyde dehydrogenase, they will convert it as acetic acid. So disulfiram, they inhibits acetaldehyde dehydrogenase, leading to the accumulation of acetaldehyde. This acetaldehyde, they will produce this headache, nausea, vomiting, hypotension. They also inactivate folate and they decrease the availability of thiamine. So when disulfiram is given, these side effects are expected. So the drug which cause disulfiram-like reactions are chlorpropamide, cefoperazone, cefamendol, ceftriaxone, griseofulvin, metronidazole, moxalactam, and procarbazine. Chlorpropamide is in sulfonylurea used for diabetes. Cefoperazone, cefamendol, ceftriaxone, they are cephalosporins. Griseofulvin is an antifungal. Metronidazole, anti-amoebic. Moxalactam is a beta-lactam antibiotic. Procarbazine is an alkylating agent used as an anti-cancer. So when there is an acute intoxication, the treatment is supportive treatment, maintenance of the fluid and electrolyte balance. Hypoglycemia has to be corrected using glucose infusion, and thiamine should be added to reverse the neurological side effects. And insulin and fructose drip has been added to accelerate the alcohol metabolism, and hemodialysis in severe case. Withdrawal syndrome. Alcohol, they produces both physical and psychological dependence. When you suddenly withdraw the drug, it produces anxiety, sweating, tachycardia, tremor, impairment of sleep, confusion, hallucination, delirium tremens, convulsion, and collapse. So treatment, the drug of choice, and which is preferred is benzodiazepines, chlordiazepoxide, diazepam. It is preferred. And other drugs like Nota, that is naltrexone, ondansetron, topiramate, acamprostate. Note that is naltrexone, ondansetron, topiramate, acamprostate. These are the drugs which is used in alcohol withdrawal syndrome. And with ethylene glycol, which is alcohol dehydrogenase, which converts into glycoaldehyde. Aldehyde dehydrogenase, they converts it into glycolic acid and oxalic acid. This oxalic acid, they form crystals in the kidney. They produce nephrotoxicity, CNS depression, and severe metabolic acidosis. And methanol, which is an wood alcohol, it is converted into formaldehyde by alcohol dehydrogenase and to formic acid by aldehyde dehydrogenase. This formic acid, they are more prone to cause ocular damage. They also produce respiratory failure, severe anion gap metabolic acidosis. So the treatment is fomepizole, which is an alcohol dehydrogenase inhibitor and is a long-acting drug. Hemodialysis is used in the severe cases. So fomepizole is the antidote, both in methanol and ethylene glycol poisoning. Next is anti-Parkinsonian drugs. Parkinsonism is a condition where there is a dopaminergic deficiency and cholinergic excess. So dopaminergic deficiency will be there. So you have to increase the level of dopamines. For that, you are giving dopamine precursor, which is levodopa, peripheral decarboxylase inhibitors, which is carbidopa and benzaraxide, dopaminergic agonists like bromocriptone, ropinirole, pramipexole, pergolide. This MAOB inhibitor and COMT, they causes the metabolism of dopamine. When you inhibit, it also will raises the dopamine level. MAOB inhibitors are selegiline and rasagiline, and Koncpt inhibitors are entacapone and tolcapone. Glutamate antagonist is amantadine. So when you give dopamine directly, it gets degraded in the periphery itself by the peripheral decarboxylase enzyme. Only few of them that dopamine will not enter into the blood-brain barrier. So we are giving us a dopamine precursor, that is levodopa. Levodopa, they gets converted into dopamine in the periphery. About 99% of the levodopa, they will get converted into dopamine in the periphery. Only 1% they will enters into the brain. To prevent this, we are giving along with peripheral decarboxylase inhibitors, so that peripheral decarboxylation of the levodopa will not happen. So the drug is carbidopa and benzaraxide. So when you use along this drug, T half of the levodopa will be increased. Levodopa, they will act for more longer time. And also it decreases the side effects caused by the peripherally decarboxylated dopamine. And the dopaminergic agonists are bromocriptone, ropinirole, pramipexole, and pergolide. And the drug which decreases the brain cholinergic system is mainly central anticholinergics, benztropine, trihexyphenidyl, procyclidine, and piperidine. These are the drug of choice for drug-induced Parkinsonism. Central anticholinergics, they are drug of choice for drug-induced Parkinsonism. And the antihistamine with anticholinergic effects like promethazine or phenadrine is also used. And coming to the adverse effects, levodopa, due to the peripherally formed dopamine, it produces dyskinesia, psychosis, hypotension, vomiting, and also on and off effects. So this levodopa is converted into dopamine by aromatic amino acid decarboxylase. When you give along with the peripheral decarboxylase inhibitor, abnormal movements and behavioral abnormalities will not be reduced. That is dyskinesia, psychosis will be same when you use along with benzaraxide and carbidopa. And tolcapone and entacapone. And this entacapone acts only in the periphery, but tolcapone, they acts both in the center and periphery. Tolcapone is potent, long-acting, but it is hepatotoxic. And salicylin, rasagiline, they are MAOB selective inhibitors. Among this, rasagiline is more potent, but the adverse effect is dyskinesia and psychosis. As it is MAOB selective, there is no cheese reactions, no tyramine interactions with this salicylin and rasagiline. Bromocriptine and pegolide, they will produce dyskinesias and psychosis. Because of the ergot action, they have vasospasm, cardiac valvular defects. Benztropine and trihexyphenidyl, they are drug of choice in drug-induced Parkinsonism. Amantadine is an antiviral drug which is used for influenza infections. They produces ankle edema and livedo reticularis as its side effect. Livedo reticularis. Propinerol and pramipexole, they are long-acting. They do not produce vasospasm. This propinerol is used in restless leg syndrome. But the adverse effect with this drug is they produce excessive daytime sleepiness, hypersexuality, and pathological gambling. Bromocriptine, it is used mainly for hyperprolactinemia, acromegaly, and diabetes mellitus also. So this is anti-epileptics. You see the mechanism of action of anti-epileptics. So first is prolongation of sodium channel inactivation and facilitation of GABA-mediated chloride channel opening, and decreasing the glutamic acid levels, and decreasing the calcium influx to T-type channels. These are the 4 common mechanism of action of anti-epileptic drugs. Valproate being a broad spectrum anti-epileptic, so it will comes for all the mechanism. Valproate வந்து எல்லாத்துலயுமே இருக்கும். Valproate in sodium channel, GABA-mediated, glutamate inhibition, calcium influx decrease. Valproate will be seen in everything because it is a broad spectrum anti-epileptic. And other drugs like phenytoin and carbamazepine is used. And LLT, that is lamotrigine, lacosamide, and topiramate. It will comes எப்பயுமே lamotrigine, lacosamide, topiramate மூணுமே ஒரே மெக்கானிசம்க்கு வரும். And zonisamide for sodium channel inactivation and calcium influx. இது ரெண்டுத்துக்கு மட்டும் தான் zonisamide. And GABA mediated chloride channel opening. We already know barbiturates and benzodiazepines, they act on the GABA mediated chloride channel opening. And valproate, it is in broad spectrum anti-epileptic, so it also comes under this. Other drugs, எல்லாத்துமே central gabapentin, the gabapentin. So in center you have GABA, thiagramin, so GABA. So GABA related drugs எல்லாமே GABA mediated chloride channel opening வந்துரும். And by inhibiting the glutamic acid, it is felbamate. They act by inhibiting the NMDA receptors. I already said valproate is a broad spectrum anti-epileptic, and there's LLT, lamotrigine, lacosamide, topiramate. It also comes. And phenytoin, phenobarbital, and levetiracetam. They are other drugs which acts by inhibiting glutamic acid. And the drug which inhibits the type T channels are valproate, ethosuximide. So these drugs, they are used mainly in the absence seizures by decreasing the influx of the calcium influx in the T channels in the thalamic neurons. So valproate, ethosuximide, and zonisamide. And the drug which acts by inhibiting the SV2A protein is levetiracetam. And CRMP2 inhibitor, that is collapsin response mediated protein inhibitor, is lacosamide. So you should not abruptly withdraw the anti-epileptic because it itself will precipitate the seizures. So this is the least teratogenic anti-epileptic is. In the older drug, it is carbamazepine, and the newer drug, it is lamotrigine. And the drug of choice for each type of seizure, for absence seizure, it is valproate and ethosuximide. Ethosuximide, it is mainly for children less than 2 years. And for GTCS, myoclonic seizures, atonic seizures, it is valproate, which is a broad spectrum anti-epileptic. And for partial seizures, it is carbamazepine. And for infantile spasms, it is ACTH. For febrile seizures, per-rectal diazepam. For status epilepticus, it is IV lorazepam. If it is status in eclampsia, it is magnesium sulfate. In carbamazepine, it is a drug of choice for trigeminal neuralgia. Main adverse effect with carbamazepine is they produces dilutional hyponatremia because they increases the ADH secretion, so that it is used in diabetes insipidus. And other side effects are megaloblastic anemia, osteomalacia, aplastic anemia. Valproate, they are used for the bipolar disorders and migraine. Main adverse effect is they causes hepatotoxicity, pancreatitis, alopecia occurs. And ethosuximide, it is also used in absence seizures. Mainly GI distress is the side effect. And felbamate, it is used in Lennox-Gastaut syndrome. Benzodiazepines and valproate is also used in Lennox-Gastaut syndrome, but it causes aplastic anemia, felbamate. Lamotrigine, main dose-limiting adverse effect of lamotrigine is rash. Once rash occurs, you have to withdraw the drug. Most commonly asked question also. Which anti-epileptic drug produces rashes? Lamotrigine. Gabapentin, they are used in neuropathic pain. That is in post-herpetic neuralgia. It causes sedation and dizziness. And topiramate, vigabatrin, tiagabin, they are also used in partial seizures. But topiramate, they causes renal stones, weight loss, and word finding difficulty. In tiagabin, it causes flu-like symptoms. Vigabatrin, they causes visual disturbances and psychosis, depression. Vigabatrin, visual disturbances. The drug which causes renal stones are zonisamide and topiramate, because they have carbonic anhydrase inhibiting action. And phenytoin is a drug which is non-sedating. It follows saturation kinetics. It is an antiarrhythmic drug also. So IV fosphenytoin is more water soluble. Acute toxicity when it causes arrhythmias and cerebellar symptoms. That is nystagmus, ataxia, diplopia, and vertigo. Chronic toxicity, they produces 5H. Hyperglycemia, hirsutism, hypertrophy of gums, hypersensitivity reactions, Hidentoin syndrome. That is when it is used for the pregnant woman, they produces Hidentoin syndrome, osteomalacia, and megaloblastic anemia. So 5H, osteomalacia, and megaloblastic anemia is the adverse effects with phenytoin. Now, coming to the next group, antidepressants. So when the depression occurs, when there is a depletion of noradrenaline, serotonin, and dopamine, it produces severe depression. So antidepressants, they have to raise these levels. That is noradrenaline, serotonin, dopamine levels has to be raised by the antidepressants. And brain-derived neurotrophic factor, if it gets decreased, it will also produce depression. So tricyclic antidepressants, it is noradrenaline serotonin reuptake inhibitors, predominantly noradrenaline reuptake inhibitors. Predominant is desipramine, nortriptyline, and reboxetine. And non-selective is imipramine, amitriptyline, trimipramine, doxepin, dortipin, and clomipramine. So they are mainly used in major depression, phobia, panic states, OCD. But for these conditions, the drug of choice is SSRIs, selective serotonin reuptake inhibitors. But this drug also used for these conditions, but the drug of choice is SSRIs. And it is also used for neuropathic pain and enuresis also it is used. But the drug of choice for enuresis is desmopressin. The side effect is they produce muscarinic and alpha blockade. They reduces the seizure threshold. They produces cardiotoxicity, weight gain, and sedation. And MAO inhibitors, the drugs of phenelzine and tranazicromine, they inhibit both MAO-A and MAO-B. MAOB inhibitors we seen in Parkinsonism. Here they inhibits both. So MAO, they are involved in degradation of noradrenaline, serotonin and dopamine. MAOB is mainly involved in the degradation of dopamine. So main adverse effect with this drug is they produce weight gain, M blockade, that is muscarinic blockade, orthostatic hypotension, and main thing is drug interactions. Hypertensive crisis occurs with tricyclic antidepressants when you give cheese because these cheese they contain tyramine. They MAO inhibitors they will inhibit both MAO A and MAO B, so they will escape the degradation and enters into the body. Lot of noradrenaline, indirectly acting sympathomimetics are activated. They increase the release of noradrenaline, leading to vasoconstriction, producing hypertensive crisis. And along with SSRIs, they produce serotonin syndrome because they increase the levels of serotonin when you given along with SSRIs. When you give with pethidine, they produce hyperthermia, hypertension, and seizures. Because pethidine, they have metabolism by two steps. One is hydrolysis, one is demethylation. These MAO inhibitors, they inhibit the hydrolysis step. So more demethylation occurs, more norpethidine will be produced. Norpethidine, they have an excitatory effects, so that they produce seizures, hyperthermia, and hypertension also. And SSRIs, they are selective serotonin reuptake inhibitors. Among this, fluoxetine is the longest acting drug. Fluoxamine is the shortest acting. Paroxetine is teratogenic, sertraline and citalopram. They are the first choice of drug in depression, panic attacks, OCD, post-traumatic stress disorder, phobia, bulimia, eating disorders, anxiety disorders, premenstrual dysphoric disorders. They are the first choice of drug. Side effects, they causes nausea, sexual dysfunction, weight loss, but except paroxetine. Paroxetine, they causes weight gain. And there is an abnormal bleeding because it involves the serotonin in the platelets also. Toxicity is serotonin syndrome because the serotonin, they inhibit when it is given along with tricyclic antidepressants, they inhibits their metabolism, leading to their raised levels. So they produce a serotonin syndrome. So SNRI, with SNRI, that is serotonin noradrenaline reuptake inhibitor. The drug is venlafaxine, desvenlafaxine, duloxetine, and milnacipran. Now, most commonly, how they will ask is which is the NDRI, which is the NARI, which is NASA. Likewise, NDRI, ND, dopamine, only one drug, that is bupropion. It is a drug used in smoking cessation also. Noradrenaline dopamine reuptake inhibitor, NDRI, only bupropion. And NRI, noradrenaline reuptake inhibitor, only noradrenaline, so reboxetine. NASA, that is noradrenergic specific serotonergic antidepressant. It is mirtazapine. It causes weight gain. It also produces alpha-2 blockade. And SARI, that is serotonin antagonist and reuptake inhibitor. It is trazodone and nefazodone. Trazodone, they produces arrhythmias and priapism. Nefazodone, they causes hepatotoxicity. NSRE, that is serotonin reuptake enhancer, or adrenaline serotonin reuptake enhancer. This tianeptine and amineptine. REMAS, that is reversible inhibitor of monoamine oxidase A. That is moclobemide. They do not produce any cheese reaction. Among this, very much important is NDRI, that is noradrenaline dopamine reuptake inhibitor, bupropion, because it is used for smoking cessation also. So the drug which produces sedative effect is amitriptyline, doxepin, and trazodone. They produce a sedative effect. But bupropion, because they are stimulant, they release the dopamine. And SSRI, they have stimulant effect. Antipsychotic. So antidepressant with antipsychotic effect is amoxapine. Most commonly asked question. Antidepressant with antipsychotic effect. It is amoxapine. So no weight gain. SSRIs will not cause any weight gain except paroxetine. With sexual problems, you can use trazodone, bupropion and mirtazapine, but SSRIs are avoided. Now coming to the anti-anxiety drugs, the drug of choice for the acute attack is benzodiazepine. But generalized anxiety disorder, a drug of choice is SSRI. So acute attack, it is benzodiazepine. For chronic disorder, that is generalized anxiety disorder, it is SSRIs. So among the benzodiazepine, chlordiazepam is used for chronic anxiety. Lorazepam, diazepam, alprazolam, they are used for short-lasting anxiety states. And azapirones, they are partial agonist at 5-HT1A receptor. They are buspirone, gepirone, ispapirone. So these drugs will not produce sedation. Non-sedative anti-anxiolytic drug is the commonly asked question. Non-sedative anti-anxiolytic drug. It is azapirones, buspirone, gepirone, ispapirone. And beta blockers like propranolol, they are used for performance anxiety. And the antihistamines like hydroxyzine, they are first generation antihistamine. They are used for sedation. And for ADHD, it is methylphenidate and atomoxetine is the drugs used in ADHD. Methylphenidate, they have amphetamine-like action. They produce agitation, restlessness, insomnia, and cardiovascular toxicity. And atomoxetine, they are selective noradrenaline reuptake inhibitor. And mood stabilizers, it is lithium carbonate, carbamazepine, sodium valproate, lamotrigine, olanzapine, and risperidone. So among the sodium valproate, they are drug of choice for rapid cyclists. Lamotrigine, it is mainly used for maintenance phase and also used in the depressive phase of mania. So lithium, the main uses, along with benzodiazepines, it is used for acute manic episode, for prophylaxis in bipolar depression, and recurrent neuropsychiatric illness, cluster headache, it is used. They causes leukocytosis. So they are used in cancer chemotherapy induced leukopenia and agranulocytosis. And they are used in inappropriate ADH secretion syndrome. So they have a narrow therapeutic index. So for maintenance, it should be maintained at the level of 0.5 to 0.8 milliequivalents per liter. For acute treatment, it has to be maintained at the level of 0.8 to 1.2 milliequivalents per liter. So the adverse effect are, they have narrow therapeutic index. They produce nausea, vomiting, diarrhea, thirst, polyuria. Fine tremors occurs initially, but when there is a toxicity with the lithium, it will produce quiet tremors also. CNS toxicity, renal diabetes insipidus, life-threatening seizures, hypothyroidism, goiter. It should not be used in pregnancy and in sick sinus syndrome. They produces Epstein's anomaly. When it is used for a pregnant woman, it produces Epstein's anomaly, cyanotic heart disease. And this is antipsychotics. And the first three columns are typical antipsychotics. And the fourth column is atypical antipsychotics. So atypical antipsychotics are clozapine, quetiapine, olanzapine, risperidone, cetrindole, ziprasidone, and aripiprazole. So what is the mechanism of this antipsychotic? It produces dopamine blockade in the limbic area. That's the therapeutic effect. That is antipsychotic effect. But in the basal ganglia also, they produce the dopamine blockade, so that they produces Parkinsonism as its side effect. And as it produces D2 blockade in the chemoreceptor trigger zone, they have an antiemetic effect. So the antipsychotics, they produces antiemetic effect. They are D2 blockers except thioredoxin. They do not have any antiemetic effect. And the pituitary, they produces hyperprolactinemia in the hypothalamus, hypothermia, and the cortex sedation. The classical antipsychotics, they are mainly D2 blockers, but atypicals, they are weak D2 blockers. but they blocks mainly serotonin receptors. And alpha receptors, muscarinic receptor, histaminic receptors, they are blocked by both the group. But the main thing is classical, they are D2 blockers. Atypicals, they are weak D2 blockers. The aripiprazole, brexpiprazole, cariprazine, they are newer drugs. They have partial D2 agonism. So this is the difference between typicals and antitypicals. Typicals, they produces extrapyramidal syndrome because they are high potency drugs. They are produce D2 blockade more. So due to D2 blockade in the basal ganglia, EPS will be more. Among the typicals, which produce the least EPS effect is thyroidazine. And why it produces least EPSs? They have M blockade, alpha blockade, and also they have anticholinergic effects. Because of the anticholinergic effect, drug-induced effects, drug-induced extrapyramidal syndrome will be less. So thyroidazine, they produces the least EPS. And chlorpromazine, they produce cholestatic jaundice, ocular dysfunction as its side effect. Thyroidazine, they produces cardiotoxicity and retinal deposits. This fluphenazine and haloperidol, they are high potency drugs. So EPS is more with these drugs. And atypical agents, what's the difference is they relieve both positive and negative symptoms, but typicals they relieve only the positive symptoms. And it can also be used in resistant cases. But EPS is less with the atypicals, autonomic effect is less, and also less hyperprolactinemia. But risperidone is a drug which causes hyperprolactinemia. In atypicals, risperidone they causes hyperprolactinemia. But the disadvantage with this atypical is they produces the metabolic syndrome, weight gain, hyperglycemia, hyperlipidemia occurs. And also they produce agranulocytosis and seizures incidence is more with this drug. This hyperlipidemia is more in clozapine and risperidone, and mainly agranulocytosis with clozapine. So atypicals, they are weak D2 blocking but potent serotonin blocking. This clozapine, they have anticholinergic effect, but they produces increased salivation. So usually the anticholinergics, they causes dryness of the mouth, but they produce increased salivation. So it is called as paradoxical hypersalivation. And agranulocytosis, myocarditis are the most common side effects of this clozapine, but they do not produce any EPS. Risperidone is the one of the atypical agent which causes hyperprolactinemia. Usually atypicals will not cause hyperprolactinemia, but risperidone they causes hyperprolactinemia. So the metabolic complication is least with ziprasidone. No improvement in negative symptom is quetiapine. Antipsychotic with anxiolytic effect is ziprasidone. Antipsychotic with antidepressant effect is amisulpride. So listen to the question whether it is antidepressant with antipsychotic effect or antipsychotic with antidepressant effect. So antipsychotic with antidepressant effect is amisulpride. Antidepressant with antipsychotic effect is amoxapine. So antipsychotic which is given through sublingual route is azinapine. Antipsychotic which is given as an inhalational powder is loxapine. So adverse effect mainly extrapyramidal symptoms, that is Parkinsonism. The treatment is central anticholinergics. Acute dystonias, it occurs while starting the therapy. With this few hours of a single dose, acute dystonias will occur. It is also treated with central anticholinergics. Akathisia, it is a motor and psychological restlessness. It occurs in 1 to 8 weeks of therapy. There is no specific antidote for this, but benzodiazepines and central anticholinergics, they will reduce the intensity. Tardive which is in purposeless movements, they occurs late in therapy. It occurs mainly due to the dopamine supersensitivity. So dopamine regulators has to be used. That is vesicular monoamine transmitters inhibitors, transfer inhibitors, that is deutratetrabenazine and valbenazine is used. And malignant neuroleptic syndrome, It usually occurs 10 days and even after withdrawal. So there are symptoms of fever, rigidity, tachycardia that occur with increase in creatine kinase levels. Mechanism behind this mainly due to dopamine antagonism. So treatment is external cooling of the body, bromocriptine and dantrolene. So the thing is, they will ask you which EPS will occur first. That is, which thing is expected first is acute dystonia, because it occurs within the few hours of therapy. And tardive dyskinesia, they occurs late in therapy. And this EPS is due to super sensitivity of the dopamine. And malignant neuroleptic syndrome, they occurs mainly to the dopamine antagonism. And coming to the opioids, it acts mainly through the mu, kappa, and delta receptors. And this endogenous endorphins, they act in the mu receptor. Hello.
Yes, ma'am. Start. Hello, ma'am. Hello. Hello, ma'am. Hello. Hello. Ma'am, start, ma'am.
Hello.
Okay, ma'am. Okay, ma'am.
So, hello. Audible இருக்கா sir? Okay, sir. So the opioids, they act mainly through three receptors, mu, kappa, and delta. Endorphins, they act in the mu receptor, enkephalins in delta, and dynorphins in the kappa receptors. Morphine is the prototype mu agonist. So mu receptor actions, kappa and delta receptor actions, they all produces analgesia and respiratory depression. But mu they causes euphoria, but kappa receptors they are more prone to cause dysphoria and psychotomimetic effects. And meiosis occurs muscular rigidity and they reduces the GI motility. Physical dependence occurs with mu and kappa receptors. But delta receptor they are mainly a pro-conversant. They affects the behavior. So mu they produces euphoria, kappa they produces dysphoria and psychotomimetic effect, and delta it is a pro-conversant. Natural opium alkaloids, it is morphine and codeine. Semisynthetic is diacetyl morphine, codeine and ethyl morphine. Semisynthetic la morphine, codeine and the madri names odru. Diacetyl morphine, codeine, ethyl morphine. Semisynthetics la. Synthetic la it is pethidine, fentanyl, methadone, tramadol and dextropropoxyphene. And mixed opioid agonist and antagonist. Kappa analgesic, it is buterphenol. It acts on the kappa receptors, buterphenol. And the drug which has kappa agonist and mu antagonist action is nalbuphine and pentazocine. Buprenorphine, they have mu agonist, kappa and delta antagonist. So morphine, they undergo glucuronidation. They produces morphine 6 glucuronide and morphine 3 glucuronide. It will be produced normally, but when it is given in renal dysfunction cases, they will produce this neuroexcitatory state. So caution in renal dysfunction. In the cardiovascular system, they produces vasodilatation. In GI, they decreases peristalsis. They produces constipation as its side effect. In genitourinary system, they produces urinary retention, urgency to void. In biliary, they increases the pressure. So it should not be given in the undiagnosed abdominal pain. In pupils, they produces meiosis. So it should not be given in head injury because in head injury itself, they produces nausea and vomiting. Morphine also stimulates this CTS and produces nausea and vomiting. We cannot able to differentiate whether the pupillary change is due to head injury or due to the morphine effect. So it is contraindicated in the head injury. It also increases the histamine release. So it is not to be used in bronchial asthmatic. Caution should be there. Abuse liability. Tolerance develops to all the effects except in meiosis and constipation. And withdrawal effects, they produces the yawning, lacrimation, rhinuria, salivation, anxiety, sweating, headache, muscular cramps and spasms. So where this opioids are used is IV morphine. It is used in myocardial infarction and pulmonary edema. Codeine, codeine, dextromethorphan, noscapine, they are used as in cough suppressants. Loperamide and diphenoxylate, we have seen in the GIT itself, it is used in non-infective diarrhea. Morphine, it is also used in pre-anesthetic medication. Pethidine, it reduces the shivering after anesthesia. Methadone, it is used in neuropathic and cancer pain. Methadone is also used in opioid abuse and opioid withdrawal effects. Opioid withdrawal also, you can use methadone. Tramadol, it is a mu agonist. They do not produce any addiction. Among this, pethidine and pentazocine, they produces tachycardia. It's not used in myocardial infarction. Buprenorphine is resistant to naloxone withdrawal. Naloxone reversal. When you give naloxone for opioid poisoning, but buprenorphine is alone resistant to naloxone reversal. Pethidine, I already said, when you give along with MAO inhibitors, it interferes with hydrolysis, but not with demethylation. More norpethidine is produced, which has an excitatory effect, so that they produces seizures. And opioid antagonists, they are pure opioid antagonists. There is naloxone, nalmefene, naltrexone, and methyl naltrexone and albumin. Naloxone, it is used in acute opioid poisoning and neonatal resuscitation. Nalmefene, it is available in the injected form, and naltrexone, it is given per orally. It is used for the maintenance of opioid poisoning, relapse after de-addiction, and they prevent the alcohol craving in chronic alcoholics. And methyl naltrexone and albumin I already said it is used in opioid-induced constipation because they blocks the peripheral opioid receptors. For opioid de-addiction, short duration, you can go with beta blockers and clonidine. For long duration of maintenance, it is methadone, which is a long-acting opioid. To prevent the relapse, peroral naltrexone. They blocks all three opioid receptors. The drugs for Alzheimer's disease, it is mainly anticholinesterase like donepezil, rivastigmine, and galantamine. Among the stacrines, more hepatotoxic. Memantine is a drug which acts by NMDA antagonist action. For Huntington's chorea, D2 blockers, that is antipsychotics, are used. Chlorpromazine, haloperidol, and olanzapine. And dopamine depleter like tetrabenazine, reserpine can also be used. For amyotrophic lateral sclerosis, it is riluzole, which is an MDA antagonist, is used. For multiple sclerosis, to decrease the frequency of relapse, beta interferon and glaciamer is used. For reducing the spasticity, muscle relaxants like baclofen and tizanidine is used. Natalizumab is a monoclonal antibody. The adverse effect is they produce PML, progressive multifocal leukoencephalopathy, and fingolimod, which is a sphingosine 1-phosphate receptor modulator, and dalfampridine, which is a potassium channel blocker. You know the drug names alone, the drugs which is used for multiple sclerosis. And in Wilson disease, it is D-penicillamine, trientine, and zinc sulfates. Shall we have a break for 5 minutes, sir? Sure. So next is drugs acting on kidney. Am I audible?
Yes, ma'am.
So this is diuretics. It is high ceiling, medium ceiling, and weak diuretics. High diuretics, they are loop diuretics. The mechanism is they act by inhibiting sodium, potassium, and 2Cl minus. It is furosemide, bumetanide, and toracimide. And the medium efficacy diuretics are thiazides. They are hydrochlorothiazide, hydrofluormethiazide, and benzthiazide. And others are thiazide-like. It is chlorthalidone, metalazone, zipamide, indapamide, and clopamide. The weak diuretics are carbonic anhydrase inhibitors, potassium-sparing diuretics, osmotic diuretics. So among this, the question will be, which is the high ceiling diuretic? Which is the medium ceiling diuretic? High ceiling is loop diuretics. And the mechanism of action is it acts by inhibiting sodium, potassium, 2Cl minus. And thiazides, they act by inhibiting sodium chloride import. And the important thing is potassium sparing diuretics. The aldosterone antagonist is spironolactone and eplerenone. Renal epithelial sodium channel inhibitors of amiloride and triamterene. So site where this drug acts is in proximal convoluted tubule. It is carbonic anhydrase inhibitors, proximal tubules. Loop of Henle. It is loop of Henle, LO. So loop diuretics and osmotic diuretics. In distal tubule and collecting duct, it is thiazides and potassium sparing diuretics. And urinary electrolyte excretion, all the diuretics, that is furosemide, thiazide, acetozolamide, spironolactone, amiloride, mannitol, they causes the excretion of sodium. In potassium, this potassium sparing diuretic like spironolactone and amiloride, they decrease the potassium excretion. And they cause the excretion of chloride and HCO3 minus bicarbonates. And the body pH altered by this diuretics, loop and thiazide, they produces metabolic alkalosis. And carbonic anhydrase inhibitor and potassium sparing diuretic, they produces metabolic acidosis. This loop diuretics, they lose calcium. So they increased calcium excretion. So they used in the treatment of hypercalcemia. Thiazides, they decrease the calcium excretion so that they are used in recurrent calcium stones. So carbonic anhydrase inhibitors, they act mainly on the proximal tubule. It is acetozolamide. They are non-competitive reversible inhibitors. Acetozolamide, they have a sulfone group in this. So they produces hypersensitivity reaction. It should not be used in liver disease. They precipitates the hepatic coma. They are used in GAVE, that is glaucoma, alkalinization of urine, mountain sickness, and epilepsy. This is with acetozolamide. And loop diuretic, they are the diuretic of choice in renal failure. Mainly furosemide, they has vasodilatory effect. So they are used in left ventricular failure and pulmonary edema. It is used in acute renal failure, hypercalcemic states, because loop diuretics, they lose calcium and therefore used in refractive edema. Among this, the most potent drug is bumetanide, highly ototoxic ethacrenic acid, and the long-acting drug is torsimide. So this drug, they decreases positive as well as negative free water clearance. But thiazide, they decrease only the positive free water clearance. So the adverse effects with thiazide and loop diuretics, they causes hypokalemia, hypomagnesemia, hyponatremia, alkalosis, they causes hyperglycemia, hyperuricemia, and impotency is more common with thiazide diuretics. Osmotic diuretics, they are used mainly in the treatment of glaucoma, cerebral edema. In cerebral edema, it is a drug of choice. It should not be used in active bleed, that is active cerebral hemorrhage. It should not be used in acute renal failure and also in pulmonary edema, because they cause the expansion of ECF volume, so they should not be used in pulmonary edema. Thiazides, they are not indicated in renal failure. Loop diuretics are the diuretic of choice in renal failure. But in thiazides, metolazone alone can be used in the renal failure. Chlorthalidone is a drug which is the longest acting. They all have carbonic anhydrase inhibitory action except indapamide. They do not have carbonic anhydrase inhibitory action. It is used to treat the kidney stones, pulmonary edema, and also it is used in diabetes insipidus. Potassium sparing diuretics is the only diuretic that acts from the interstitial state. All other diuretics, they produce action by acting over the tubular lumen. Spironolactone only, they act mainly from the interstitial side. And candidone is the active form of spironolactone. Eplerenone is a selective aldosterone antagonist. Amiloride, it is used for the lithium-induced diabetes insipidus. It is a drug of choice. Triamterene, it is not much used nowadays because they produces renal stones and impaired glucose tolerance. So in this slide, very much important is spironolactone. They produce its action from acting from the interstitial side. But all other diuretics, they act mainly from the luminal side. Spironolactone, they are used in congestive heart failure, cirrhotic edema, and hirsutism. In cirrhotic edema, the aldosterone levels are high. So in this condition, you can go with spironolactone. ADR caused by it causes gynecomastia, impotence, and hyperkalemia because they are potassium sparing diuretics. And antidiuretics, mainly three receptors, V1, V2, V3. For releasing the ADH, it is mainly through V2 receptor. Antidiuretic hormone releases mainly the V2 receptor. V1, the location is vascular smooth muscle, platelets, and hepatocyte. And V2 is the one present in the kidney and endothelium. And V3, the anterior pituitary. So V1, they are concerned with vasoconstriction, vascular smooth muscle contraction, platelet aggregation, and glycogenolysis. So V1, vasoconstriction. V2, they are present in the kidney. They are having antidiuretic hormone release. They increase the release of factor 8 and von Willebrand factor. So vasodilatation. They produce vasodilatation also. And V3, they cause the release of ACTH. The mechanism of action is V1 by GQ receptor. They increases the phospholipase IP3 diacetylglycerol, thereby increasing the calcium influx, producing the vasoconstriction. And GS receptor, they increases the cyclic AMP, thereby producing vasodilatation. This is also GQ receptor, increases the calcium levels, thereby causing the release of ACTH. Arginine vasopressin, they are non-selective. They are active in the V1, V2, and V3 receptor. And terlipressin is the V1 selective receptor. It is used in the bleeding esophageal varices. And desmopressin, it is the V2 selective. It is used in central diabetes insipidus, von Willebrand's disease, and nocturnal enuresis. It is the drug of choice in hereditary diseases and nocturnal enuresis. Von Willebrand disease, it is also desmopressin is used. And V3, it is arginine vasopressin, which is non-selective drug. And lepressin is an V1, V2 non-selective drugs used in bleeding esophageal varices, but it is a non-selective one, lepressin. Desmopressin, they are available in the intranasal route also. They produces nasal irritation and rhinitis as its side effects. Vasopressin, they causes hypertension and precipitation of angina because mainly by activating on the V1 receptors. And the drugs like thiazides, it is used for both central and nephrogenic diabetes insipidus. Desmopressin, chlorpropamide, carbamazepine, they are used only for central diabetes insipidus. So thiazide is a drug which is used both in central and nephrogenic diabetes insipidus. And vasopressin receptor antagonist, we already know V1 is involved in vasoconstriction. So V1 receptor antagonist, they are used for hypertension and heart failure. V2 is the receptor which increases the release of ADH. So it is used in the syndrome of inappropriate ADH release. and non-selective drugs. Kontavaptan is a drug which is a non-selective vasopressin receptor antagonist. This tolvaptan, mozavaptan, and lixivaptan, they are V2 selective, and velcovaptan is V1 selective. Kontavaptan, they also used in SIADH only because they are non-selective action. They are used in SIADH. Now coming to the cardiovascular system, first is the drugs for heart failure. It is for acute heart failure and chronic heart failure. So acute heart failure, you have to increase the contractility of the heart and to relieve the congestive symptoms. So that inotropic drugs, diuretics, AC inhibitors, angiotensin receptor blockers, vasodilators, and synthetic BNP analogs are used. For chronic heart failure, you have to reverse the remodeling happen. That is, for that AC inhibitors, angiotensin receptor blockers, beta blockers are used, aldosterone antagonists. These drugs, they reverse the remodeling. So beta blockers, it should not be used in decompensated heart failure. And ivabradine is a drug which acts by inhibiting the funny-cation channel. So ivabradine is also known as bradycardia causing agent. It can be used when the beta blockers are intolerant to a patient. So ivabradine should not be used when the heart rate is less than 70 per minute. And vasopeptidase inhibitors, they are used for chronic heart failure. So the drug which decreases the preloader, diuretics, AC inhibitors, angiotensin receptor blockers, and venodilators. Venodilators, they decrease the preload. Arteriolodilators, they decrease the afterload. So AC inhibitors and angiotensin receptor blockers, they decrease the afterload. So contractility, increased contractility is caused by inotropes, that is digoxin and beta agonists like dopamine and dobutamine. Dopamine, that acts mainly in the three receptors, D-bar, D, B, and A, D-bar. Dopamine, beta, and alpha. Dopamine in the dose range of 1 to 2 microgram per kilogram per minute, they produce renal vasodilatation. Beta in the dose of 2 to 10, they stimulates the heart. When that is given more than 10 mics, it produces vasoconstriction. Dobutamine, they do not act on the dopamine receptor. They act on the beta receptors. And the drug which reverses the remodeling of the cardiac muscle is AC inhibitors, angiotensin receptors, spironolactone. And inodilators. Inodilators, they causes the contraction of the heart muscle and also they produces the vasodilatation. Mainly phosphodiesterase 3 inhibitors like amrinone, milrinone. Amrinone, they are more prone to cause thrombocytopenia. Amrinone and milrinone, they both will cause arrhythmias as its side effect. So they increases the camp and heart muscles, they increase the calcium influx leading to inotrophy. And they increases the camp and smooth muscles, thereby decreasing the total peripheral resistance. So they produce inodilatory effects. And levosimendan is also an inodilator. Usually this is asked as which is a calcium sensitizer. It is levosimendan. They sensitize the myocardium to calcium by binding to troponin C. They are popularly called as calcium sensitizer. And the recombinant BNP analog is nesritide. They act mainly by increasing the cyclic GMP. So sacubitril, it is a neprilysin inhibitor. Normally BNP analogs, they produces vasodilatation effects. BNP is degraded by the vasopeptidase enzymes. So this vasopeptidase enzyme will causes the degradation of the BNP. Neprilysin, they prevents the degradation of the BNP by inhibiting the vasopeptidase enzyme. And vasopeptidase inhibitors are omapatrilat and samapatrilat. They inhibit the degradation of the BNP. But the main adverse effect with this group is they produces angioedema as its side effect. And AC inhibitors, all AC inhibitors are prodrugs except captopril and lisinopril, CL. So all are prodrugs except captopril and lisinopril. So these drugs, they ends with pril. So they are used in the heart failure, hypertension, myocardial infarction, diabetic nephropathy, scleroderma, renal crisis. The main adverse effect is they produces cough as a side effect. Angioneurotic edema because of the raised bradykinin levels. Icatibant, it is a bradykinin antagonist used for this condition, angioneurotic edema, and it is also teratogenic. It produces first dose effect, hypotension, hyperkalemia. Caution should be there when it is used along with potassium sparing diuretic. They produces renal failure, dysgeusia, and neutropenia. So contraindication, it should not be used in pregnancy, bilateral renal artery stenosis, severe renal failure, and hyperkalemia. So all are prodrugs except CL, captopril and lisinopril. Main adverse effect is cough. Digoxin, it is the only I know drug which is given orally. Its mechanism of action is it acts by inhibiting the sodium potassium ATPase. So they have long T-half, so loading dose has to be given. It is excreted through the kidney, so caution in renal impairment. They have large volume of distribution. It has good plasma protein binding. So this verapamil and quinidine-like drugs, they displace the digoxin from the plasma protein, leading to increasing the digoxin levels. So verapamil and quinidine, they enhances the digoxin toxicity. So where it is used in congestive heart failure, atrial fibrillation, atrial flutter, and paroxysmal supraventricular tachycardia. But the drug of choice for PSVT is adenosine. It is used, digoxin is used in this condition. But it should not be used in Wolff-Parkinson-White syndrome because it decreases the conduction only in the AV node, but not in the aberrant pathways. So it is not used in the Wolff-Parkinson-White syndrome. So the most common adverse effect is nausea and vomiting. And which is the early occurring adverse effect is nausea and vomiting. And others are gynecomastia, visual effects, xanthopsychosis, yellow vision, hallucination. And most common cardiac side effect is cardiac arrhythmias. And most common cardiac arrhythmia is ventricular bigamy. So how do you treat the toxicities? For ventricular toxicity, ventricular arrhythmias, it is lignocaine and phenytoin. For supraventricular arrhythmias, it is propranolol and digibind. It is used for the treatment of toxicity. And the toxicity is increased by diuretics, which decreases the potassium, magnesium level and increase the calcium levels. And quinidine and verapamil, they enhances the toxicity of digoxin. Coming to the antiarrhythmic drugs, class 1 is sodium channel blocker, 2 is beta blocker, 3 is potassium channel blocker, 4 is calcium channel blocker. 1 is divided as 1A, 1B and 1C. 1A is QPD, quinidine, procainamide, disopramide. And B, it is lignocaine and mexiletine. And C, propafenone, flecainide. So F sound, propafenone, flecainide. And beta blockers, we know propranolol, sotalol and esmolol. They are used mainly. Propanol, it is used in supraventricular tachycardia. And class 3 is potassium channel blockers. These drugs, they widen the action potential. So they are more prone for torsades pointers. The drugs are amiodarone, dronedarone, dofetilide and ibutylide. So amiodarone is a drug which has longest acting. Their T-half is for about 8 weeks. Adenosine is the drug which is shortest acting. In antiarrhythmics, amiodarone is the longest acting. Adenosine is the shortest acting. Bretalurin is a drug which produces pharmacological defibrillator. And class 4 is calcium channel blockers. It is verapamil and diltiazem. And class 5, main thing is adenosine is an important drug and digoxin. So in this classification itself, they will ask you which is the class 3 drug, which among the following is class 2 drugs likewise. So drug acting on AV node is A, B, C, D. Adenosine, beta blockers, calcium channel blockers, digoxin, A, B, C, D. for atria, ventricle, and accessory, it is third AC, likewise third AC class. That is 1A, 1C, and class 3 drugs. They act in the accessory conduction tubes. And ventricles, it mainly 1B and lignocaine. So these are the drugs which produces Tarsadis pointers, mainly in antiarrhythmics, class 1 drugs, QPD 1A, quinidine, procainamide, disopramide, and amiodarone. They causes Torsades pointers. And in antihistamines, it is terfenadine, astinazole, and avastin. And antifungals like ketoconazole, fluconazole. Other drugs we have said in cisapride. In GIT itself, we said cisapride, they are more prone for QT prolongation. Haloperidol, erythromycin, amitriptyline, and imipramine are the other drugs. So flecainide, it is used in the acute treatment of full Parkinson-White syndrome, but the treatment of choice is radiofrequency ablation. Ibutylide, they are used for the conversion of atrial fibrillation into sinus rhythm. Lignocaine, it is used in the ventricular arrhythmias due to digoxin toxicity and due to post-MI also. Verapamil, they are used for the prophylaxis of PSVT. Adenosine, they are mainly used for the treatment of PSVT. So digoxin, we have already said, it is used in atrial fibrillation flutter. They controls the ventricular rate in both the cases. And magnesium, they are used in the treatment of congenital and acute long QT syndrome. So quinidine, the main common adverse effect is synconism, that is hearing defects will be there with quinidine. Procainamide, they will produce hematotoxicity and SLE-like syndrome. Lignocaine, they are more, it's a proconvulsive, it causes seizures. Flecainide, it is pro-arrhythmogenic. So among these, amiodarone side effects are very much important. This it causes pulmonary fibrosis, phototoxicity, blue pigmentation of the skin, corneal deposits, hepatic necrosis, thyroid function, and it increases the LDL levels. So the mnemonic to remember is please check TFT, LFT, and RFT. That is please is phototoxicity, check corneal deposits. For PFT, pulmonary function, that is produce pulmonary fibrosis. That is hepatic necrosis, liver function test. TFT, it causes thyroid dysfunction. But also there is bluish pigmentation of the skin. So verapamil is a calcium channel blocker, they produces constipation. So avoid beta blocker and a calcium channel blocker together because they produces cardiac depressant effect leading to cardiac arrest. Amiodarone, they increases the toxicity of digitalis, warfarin, and theophylline. So these are the anti-anginal drugs. Is nitrates, which is glyceryl trinitrate, isosorbate nitrates, calcium channel blockers, beta blockers, potassium channel opener is nicorandil. This PFOX inhibitors like trimetazidine and ranolazine. This acts mainly by a non-hemodynamic mechanism. So these drugs, they will not alter the heart rate or pulse rate. So they reacts by the non-hemodynamic mechanism. That is, they act by inhibiting the fatty acid oxidation. So usually fatty acid oxidation occurs, they inhibits the fatty acid oxidation. So it gets converted into glucose oxidation. So the energy required for glucose oxidation is less compared to that of fatty acid oxidation. Thereby it decreases the myocardial work. So these two drugs act mainly by non-hemodynamic mechanism. And the sodium channel blocker is, it is ranolazine and ivabradine. Ivabradine is a bradycardia causing agent. And rho kinase inhibitors is fasudil. Rho kinase, they are involved in the vasoconstriction and the C-base remodeling. So fasudil, they inhibits the rho kinase. Thereby they produces vasodilatation and reverses the remodeling. Nitrates, they decreases the preload and afterload. So they produces venodilatation and arterial dilatation. Because of venodilatation, they decreases the preload, and arterial dilatation, they decrease the afterload. They also cause the release of nitric oxide, that decreases the oxygen consumption, and they produce a reduction in the end diastolic size and pressure. So among this, Nitroglycerin and isosorbate dinitrate, they are used for the acute attack. For prophylaxis, it is nitroglycerin, which is given orally or can be given for as a transdermal patch. Pentaerythritol tetranitrate, which is a long-acting drug. Amyl nitrate is the shortest acting, which can be given along with the inhalational route. So all nitrates, they undergo high first pass metabolism except isosorbate mononitrate, which has 100% bioavailability. So these are the nitric oxide donors: the sodium nitroprusside, organic nitrates, phenoldopa, propofol, and nebivolol. They causes the release of nitric oxide. There are many more drugs which causes the release of nitric oxide, like nitrandipin. So mainly due adverse effects mainly due to the vasodilatation, hypotension, tachycardia, headache, flushing, palpitation, and fainting. These are the vasodilatory side effects. And methemoglobinemia occurs, and rash is mainly due to pentaerythritol tetanitrate. So tolerance and dependence occurs with this drug. So tolerance, it requires rest period of 12 hours. That is, there will be an attenuation of the hemodynamic effects of nitrates. They will not produce vasodilatation, and they produces Monday morning headache. So use is used in angina, heart failure, MI, biliary colic, esophageal spasm. They causes the relaxation of these esophages. Cyanide poisoning, mainly sodium nitrite is used for this condition. Contraindication, should not be used along with sildenafil because profound vasodilatation leading to hypotension occurs, which itself precipitates the angina. So these are the potassium channel openers: minoxidil, diazoxide, nicorandil, pinacidil, and chromacolin. Mainly it is used in hypertension, angina, CCF. Minoxidil in alopecia. Because of the vasodilatory effect, it is used in peripheral vascular disease. These are under research only in bronchial asthma, antihypoglycemic, premature labor, erectile impotence, and urinary incontinence. Mainly minoxidil is used for alopecia. Calcium channel blockers, they blocks the L type of calcium channels. This is a commonly asked thing. Which type of calcium channel is blocked by calcium channel blockers? This L type. The drugs of verapamil, tiltiazem, and the long-acting dihydropyridines are preferred for angina because short-actings, they causes reflex tachycardia. So the long-acting drugs are preferred. The drug which has least effect on AV conduction is nifedipine, and which has longest half-life and highest oral bioavailability is amlodipine. The drug which prevents the vasospasm, which produces, which is used in cerebral hemorrhages, nimodipine, because they are cerebroprotective. So adverse drug reaction is verapamil, they produces constipation and ankle edema. So these are the drugs used in antihypertensives. We have seen diuretics. Among the diuretics, thiazide is preferred as an antihypertensive than loop diuretics. So in sympathoplegics, the alpha methyl dopa is a prodrug. So other drugs we'll see in the content itself. So potassium channel openers also we have seen, and nitric oxide releases, calcium channel blockers, AC inhibitors, ARBs, and renin inhibitors. These are the drugs used for hypertension. So when there is an benign prostatic hypertrophy, you can go for alpha blocker. In diabetes, acin-angiotensin receptors are preferred. In asthma, beta blockers are contraindicated because they produces bronchospasm. So diuretics, calcium channel blockers, AC inhibitors, and ARBs are used. In congestive heart failure, it is AC inhibitors, post-MI, beta blockers, and AC inhibitors. And peripheral vascular disease, that is vasodilators like CCBs and alpha blockers are used. In thyrotoxicosis, beta blockers. For pregnancy, it is cardioselective beta blocker like labetalol is used. Methyl dopa, clonidine, dihydropyridines like nifedipine, hydralazine is used. For opioid withdrawal, the drug is clonidine. For hypertensive emergencies in cheese reaction, it is phentolamine. For pheochromocytoma, it is phenoxybenzamine. So mecalamine, it is a drug. It is used in smoking cessation. Carvedilol, they have antioxidant effect. Minoxidil, it is used in alopecia. Diazoxide, it is used in insulinoma. Nimodapam, it is a cerebroprotective agent. It is used in subarachnoid hemorrhage. They prevents the vasospasm. So important adverse effects with this drug is methyl dopa, they produces positive Coombs hemolytic anemia. Clonidine, they produces rebound hypertension. Reserpine, they produces severe depression. Prazosin, which is an alpha blocker, first dose effect. First dose effect is common with alpha blocker. So important adverse effect. Propranolol, they produces sexual dysfunction, rises the LDL levels, rises the sugar levels. They caution should be in asthmatics, diabetics, and peripheral vascular disease. Hydralazine, they produces SLE-like syndrome in slow oscillators. Nitroprusside, they releases the cyanide ions, they produces cyanosis. It is used for more than 12 hours, they produces toxic psychosis. Minoxidil, they produces pulmonary hypertension because it shifts the volume. Diazoxide, they produce hyperglycemia. Calcium channel blockers, mainly verapamil, they produces constipation, headache, gingival hyperplasia, and proteinuria. So these are drugs used in hypertensive emergencies, parenteral and oral. Among this, nicardipine plus esmolol combination is the drug first started initially. So nitroprusside, nitrate, labetalol, hydralazine, phentolamine, furosemide. These are the parenterally used drugs. And oral is LAG, labetalol, amlodipine, captopril, and clonidine. For the treatment of pulmonary hypertension, it is bosentan and macitentan. They are non-selective endothelin receptor antagonists. Endothelin, they act mainly in the endothelin A and B receptor, and they produces vasoconstriction. So, selective endothelin A receptor antagonist, it is ambrisentan. Epoprostenol and selexipag, it is a prostacyclin analogs used in pulmonary hypertension. And phosphodiesterase 5 inhibitor is sildenafil. Soluble guanine cyclase activator is riociguat, which is used for pulmonary hypertension. So icatibant, it is a bradykinin inhibitor. It is used to treat angioedema. That is occurs mainly in AC inhibitors due to increased bradykinin levels. Dipyridamole, they shift the blood from the ischemic to non-ischemic area. So they are said to possess coronary steal phenomenon because they shift the blood from the ischemic to non-ischemic area. This is with cardiovascular system. So fibrinolytics and thrombolytics, they convert the plasminogen to plasmin, leading to the lysis of the thrombi. So the fibrinolytic agents are streptokinase, urokinase, altiplase, retiplase, and tenecteplase. So streptokinase, it is antigenic. So this retiplase and tenecteplase, they are called as bolus fibrinolytics. That too, tenecteplase, they are called as single bolus because retiplase, they are given by the two times at the 30 minutes difference. Two times they will give retiplase, but tenecteplase, it is in single bolus. But as a bolus fibrinolytics, both retiplase and tenecteplase, they are bolus antifibrinolytics. But single bolus fibrinolytic agent is tenecteplase. They are obtained from the recombinant DNA technology. So antifibrinolytics are epsilon aminocaproic acid, tranexamic acid, and A-proteinin. So what's the difference between streptokinase and altiplase? Streptokinase, they are not clot specific. So both bound and free plasminogen, they will act. So it will lead to the depletion of fibrinogen, factor 5 and factor 8. But altiplase, retiplase, tenecteplase, they are clot specific. They act mainly on the fibrin brown plasminogen. So the bleeding will be more in case of streptokinase than that of altiplase. So the streptokinase, it is derived from beta hemolytic streptococci. So it is antigenic. So when you have infections in the recent past, or you have taken the drug already in the recent past, antibodies would have formed. It will decrease the effect of streptokinase. And hypersensitivity reaction and hypotension is common with streptokinase, but there is no allergy problem with altiplase. So they are used mainly in MI, deep vein thrombosis, pulmonary embolism, peripheral arterial occlusion, and stroke. So these are the antiplatelet drugs. Thromboxane synthesis inhibitor. It is aspirin, low dose aspirin. It is used as an antiplatelet. Platelet count enhancer, dipyridamole, which is a drug causes coronary steal phenomenon. P2Y2 receptor blocker. It is cyclopirin, clopidogrel, prasugrel, and ticagrelor. They are all prodrugs. Ticlopidin and clopidogrel, prasugrel. These are irreversible. And ticagrelor, cangrelor, they are reversible antiplatelet drugs. Reversible P2Y2 receptor blockers. GP2B3 antagonists, they are TEA, tirofiban, eptifibatide, and apixaban. So GP2B3 antagonist T. Aspirin irreversibly inhibits the cyclooxygenase enzyme. Antiplatelet effect is at the low dose aspirin exerted through. Ticlopidin, clopidogrel, prasugrel, they are irreversible inhibitors. They are all prodrugs. Ticagrelor, it is a reversible inhibitor and it is orally effective. Bleeding is the most common side effect of this drug, and that too with ticlopidin, there is a severe neutropenia and thrombocytopenia. And GP2B3A inhibitors, I said it is T, tirofiban, eptifibatide, and apixaban. Apixaban is a monoclonal antibody. Tirofiban is a non-peptide. Eptifibatide, it is a peptide. So it ends with tide. So it is a peptide. Specificity is more with tirofiban and eptifibatide compared to that of apixaban. The half-life is less with apixaban, but the antiplatelet effect is prolonged with apixaban. But it is reversed with the tirofiban and eptifibatide. Half-life is about 2.5 years, but the antiplatelet effect is short. So the renal clearance of tirofiban and eptifibatide is by renal clearance. For FDA approved labeling, it is percutaneous coronary intervention, unstable angina. These drugs are used. So Varapaxar is a newer drug. It is an orally active inhibitor of protease activated receptor, PAR, proteated activated receptor, Varapaxar. So it is also used as an antiplatelet drug. Mainly it is for the prophylaxis of MI, aspirin is used. For cerebrovascular disease along with artificial heart valves, dipyridamole and warfarin combination is used. So anticoagulants, oral and parenteral anticoagulants. Oral is mainly warfarin, factor 10A inhibitor. It is rivaroxaban and apixaban. So in the 10A, in the name itself, you will have a 10A, rivaroxaban, XA, apixaban, XA. Direct thrombin inhibitors, both oral and parenteral is there, but oral it is DX, dabigatran and zymolgatran, XT or DX, dabigatran and zymolgatran. So hirudin, lepridin, bivalodin, argatroban, melagotran, they are direct thrombin inhibitors, but parenteral route. And indirect thrombin inhibitors are heparin, low molecular weight heparin, fondaparinux and idraparinux. So what's the difference between heparin and warfarin is? Heparin is the large molecule, while warfarin is a small molecule. So kinetics, heparin, there is a rapid onset of action. So it is used for the treatment. Warfarin, it is a delayed onset. That is, it has to deplete the clotting factors. So the action will be delayed. So it is used mainly for the maintenance of the case. So placenta, heparin will not cross the placenta. Warfarin, they crosses the placenta and they are teratogenic. That is, they causes chondritis syndrome. There is bone dysmorphogenesis. Mechanism is apparent by binding of the antithrombin 3 to 2A and 10A. Mainly 2A and 10A. This activation will be inhibited. So heparin, they binds to antithrombin 3. They inhibits the activation of 2A and 10A. But warfarin, they acts by inhibiting vitamin K epoxide reductase, reducing the vitamin K dependent factors like 2, 7, 9, 10. So monitoring, heparin is by partial thromboplastin time, warfarin is by prothrombin time. So heparin antagonism is by protamine sulfate, warfarin for the fast action, fresh frozen plasma is given. For slow onset, vitamin K. Vitamin K is the antidote for warfarin. So uses, it is used to initiate therapy, heparin, but warfarin for the maintenance. Same for the anticoagulation of thrombosis, emboli, unstable angina, like. And toxicity, it is about alopecia, bleeding, osteoporosis, urticaria, thrombocytopenia, secondary hyperaldosteronism, hypersensitivity reaction. And with warfarin, it is alopecia, bleeding, dermatitis. Due to low potency, they causes skin necrosis. So low molecular weight heparin. What's the difference between heparin and low molecular weight heparin is they inhibits factor 10A than 2A. So advantages, better bioavailability, they have long half-life, less thrombocytopenia, less osteoporosis, they do not require monitoring. So warfarin, protein C deficiency occurs, so they produces dermal vascular necrosis, and this they also cause some hypercoagulability. Among the factors, factor 7 was the first to disappear. For last to disappear is factor 2. 7 is the first to disappear. So it has to be, warfarin has to be stopped 7 days before surgery. If it is in venous thrombi, it is the drug of choice is anticoagulants and fibrinolytics. If it is an arterial thrombi, the drug of choice is antiplatelets. And direct thrombin inhibitors, they are the anticoagulant of choice in heparin-induced thrombocytopenia. Its adverse effect is also bleeding. So all these drugs, they are exerted in the kidney, except ergotrobon. So they are safe even in anuria. A is safe in A. Ergotrobon, it is safe in anuria. Lepirudin, they are safe in liver failure. L, lepirudin is safe in liver failure. So the antiplatelets, they prolongs the bleeding time. Anticoagulants, they prolongs the clotting time. Heparin, monitoring by partial thromboplastin time. And warfarin, the monitoring is by prothrombin time. And coming to the hypolipidemic drugs, statins, the mechanism of action is by inhibition of the HMG-CoA reductase inhibitors. Among the statins, simvastatin and lovastatin, LS, they are prodrugs. They do not have any effect on lipoprotein A. The most potent statin is pitavastatin, and the long-acting is rosuvastatin, followed by atorvastatin. They both are long-acting. So pravastatin, they decreases the fibrinogen levels. They have minimal drug interaction with other drugs. Pravastatin is also given in the young children also. So they do not have effect on lipoprotein A. Pravastatin is with least drug interactions. Bile acid sequestrant are cholestyramine, cholestyramine, and cholecyllin. Cholestyramine, cholestyramine, they are available in the sachets. Cholecyllin, they are available in the oral tablet form. They are safe in pregnancy. The lipoprotein lipase activators are clofibrate, gemfibrozil, bezafibrate, fenofibrate. See, in this fenofibrates, they are prodrug, longest half-life, and they are also uricose-uric. And lipolysis and triglyceride synthesis inhibitor, it is nicotinic acid. They decreases the lipoprotein A levels. So other things, these are newer drugs. You know the name of the drugs by seeing that classification name itself. Cholesterol absorption inhibitor is ezetimibe and avacimib. So they are absorption inhibitor. So main adverse effect with this drug is gastrointestinal distress. CETP inhibitors, that is cholesterol ester transport protein inhibitors. It is toacitrabib and anacetrabib. CET. CET is in the drug name itself. Toracetrapib and acetatrapib. And MTP protein inhibitors, that is microsomal triglyceride transport protein inhibitors, it is lomitapide. Lomitapide. Here also microsomal triglyceride MIT is there inside the drug name itself. Antisense oligonucleotide against apobase mipomycin. And PCSK, that is proprotein converting subtilisin kexin 9 inhibitors. It is alirocumab and evolocumab. These are new drugs. You know the name of the drugs alone. So among this, maximum LDL lowering effect is seen with statins. Maximum triglyceride lowering effect is seen with fibrates. Maximum HDL increasing effect is seen with niacin. So the drug which increased triglycerides among the hypolipidemic drugs, the drug which increased triglyceride concentration is bile acid sequestrants. So important adverse effects. HMG-CoA reductase inhibitors, they causes myopathy, myalgia and hepatotoxicity. Bile acid sequestrants, they produce bloating and constipation. These lipoprotein lipase activators along with HMG-CoA reductase receptor inhibitors, when they given, more myopathy occurs. And nicotinic acid, they produces flushing. It can be avoided by pre-treatment with aspirin. Now a newer drug known as laropiprant. It is an anti-flushing agent used along with nicotinic acid, but it itself does not have any hypolipidemic effects. It produces pruritus, rashes, and hepatotoxicity. And cholesterol absorption inhibitor, they mainly produces GA distress. And this is with session 1 pharmacology, and remaining topics will be continued in the second session. Thank you all.
Thank you, ma'am.